patient is may not required all the time pacing, so intermittently occasionally may require pacing. So in those scenario, we may have a pacemaker. And of course in one condition where vasovagal syncope, we can give a pacemaker, Ascens Vicens state you can see in those patients, suppose. Whereas DDD pacing, this is the ECG represents, suppose, A sense, V sense. And if the, as I told you, if the patient is not dependent, so you can see also ECG where you will not see any spike, suppose. But of course, you need to understand this patient is having a pacemaker, but we the intention to minimize the pacing. Okay.
Where
Okay.
you don't need, you don't pace. That's what he's trying to tell you. Go back one, Anand. Is this a normal sinus rhythm in a normal person? Yes. He is not having all the time atrial problems. He is not having all the time ventricular problems. That's what that he means by minimizing pacing. You don't want to pace because your pace is usually caudocranial. Your QRS starts becoming wide. Why do you need to pace? You don't need to pace, right? So this could still be a pacemaker patient without spikes. Thanks, Anand. Go on.
Okay, so A pace, V pace in comes where SA node and even AV node, below AV node blocks are typical. So the patient required in both the nodals, the heart rate is too low. In those scenario, we have to give a adequate heart rate to be maintained for the patient. So A pace to V pace. So, for example, if you program the rate at 60 or 70 as a lower rate in the pacemaker, so this is going to maintain typically like whatever fixed base rate and A base, and it creates the first spike followed. It creates a P wave, and also second spike it creates a QRS. So P and QRS will be maintained by the or produced by the pacemaker. So A pace to V sense pacing mode. So in dual chamber pacemaker. So as I told you, like 6NS syndrome, for example, you're going to pace the atria, and you are look at some of the leads. It shows negative P waves because we are not producing the natural SA node phenomenon here. Somewhere it is in the appendage. We place the lead in somewhere in the atria chamber. So it gives the abnormal P wave, but we can contract the atria. So basically, whatever heart rate adequate for the patient, as in needed, we can program 60 or 70, however we require, and we can maintain A pace and allow the AV nodal conduction. Here, there is again, it's a lot of other parameters are involved. I'll upcoming slides I'll show you, but A pace and to the followed by V sense. That is again we are allowing AV nodal conduction, natural AV node conduction. We don't want to pace here. So since only the problem is upper, and of course here we are going to maintain the AV synchrony, right? AV synchrony. That's where. So again, you can think of why can't give a AIR pacemaker here, right? So that's a question. So why dual chamber pacemaker here? So one more hardware or one more wire into the ventricular, because problem is in SA node. So here we are going to give two wires in case ventricular AV node also going forward, if in future the patient develop the AV node, and of course ventricular pacing is more important for the patient. So AIR pacemaker, of course, the criteria is we need to check Wenckebach, which means Wenckebach phenomenon, which means we are going to check the capability of the AV nodal conduction, right? If the capability of AV nodal conduction is good, so AIR pacemaker can be given, right? Otherwise, dual chamber pacemaker.
You are assuming what he's saying is you are assuming that your AV node conduction is good here. Supposing this is a 65-year-old man and you are not sure that it's only the SA node that's bad, that means you have paced the P here, right? You could have you could have gotten away with an AIR. Why did he put an extra lead? If this man develops a CHB, your AIR won't help. It will create a P, come to the AV node and stop. So how will you protect the patient? That's why he keeps a lead in the V, but he allows natural conduction. When it fails, it will take over as a pacemaker. Is it clear, guys? Yeah. Thanks, Anand.
Okay, so here you can see one more state, that is Ascens VPs, and of course, if there are AV below AV nodal conduction blocks in those scenario, we are going to give a dual chamber pacemaker. So you can see there's one spike, only the onset of the QRS. So there is no spike for the A because SA node is very good. So the physiological natural pacemaker SA node, which is very good, suppose very good, and only the problem is below AV node. So here A sense and V pace is going to maintain by the pacemaker. So as in the patient, based on the patient physical activity, the heart rate increases and reduces as naturally like SNO does, and ventricular lead or ventricular pacing, it just follows the atria. However, like the patient, even if the patient is in the rest, heart rate is maintained, for example, 60 to 70. Yes, it's maintains the ventricular rate also. It just follows the atria. That's all. Okay, it's we call it as A sense V pace state is we call it as atrial tracking. So tracking the pacemaker is tracking. That's what we call it as. So it can maintain the AV synchrony. Okay, again the let me, if you think that let me allow ventricular chamber to pace as like atria rate is goes, as in it goes higher, and is it safe? But it is not safe again. So let us see why it is not safe. So we call it as maximum track rate. We have a break for ventricular rhythm, ventricular pacing to track. So something like we need to give a break, or we have to cut off one ratio, whereas for example 130, 140, we can program uh, the maximum tracking rate, and we can allow pacemaker ventricular chambers to track the atria. So why do we require this break? Any guess? Why do we require let it track? No, let it go 150, 160, 170, 180. Why do we track? I mean, why do we require a break? So basically, let's say, as I mentioned, you see, look at this QRS. And as I told you, the RV, right ventricular pacing, it produces the left bundle branch block. And you are pacing at 150, 160, 180, for example, higher than that. So that is not safe again. It is basically, we are creating a VT. VT, what happens? Though it is a AV synchrony, but again, it's a faster rate. So faster rate patient may feel palpitation. Symptom, it will be symptomatic. So here, what you observe here in this slide is like ASIN's V pace in the, say, look at 71 heart rate, it's nicely tracked, and also like 90, yeah, it is tracked, and even 120 ASIN's V pace, you can see clearly, it is associated, and it is AV synchrony is maintained, right? There is no problem. But problem comes after maximum track rate. So as I told you that let me give a break for the, I mean, one cutoff ratio for the maximum track rate. The pacemaker after 120, if the rate sinus rate SNO rate is goes, it increases, then what problem happens? This is what it happens. Sometimes if the pacemaker programming is not proper, this can happen for patients. So some patients are very symptomatic. In that condition, let's say I have programmed in such a way that track rate is 120 or 130, 140, whatever. So suddenly, if the rate falls, the patient may get fainted. So this is what the patient was very happy and he was doing activity and no issues. Suddenly he falls. So this can happen, suppose. So fall down rate, that we call it as 2 is to 1 block rate. So 2 is to 1 block rate, something it is typical. So you see here the rate is around 120. It's nicely it's tracked, ventricular being paced, and 1 is to 1 conduction is maintained, right? PVA followed by QRS, and suddenly the rate becomes 60, right? If the track rate, if I program for example 140 or 150, so this is what it happens. It becomes it's falls 50% of what are the maximum track rate. So some patients definitely will be symptomatic, but of course this can be taken care by the pacemaker programming. So we call it as pacemaker pseudo Venkiback. Of course, Venkiback you have seen. I know Madhu sir has explained. How Venkiback in second degree AV block. So similarly here, like you can see the progressively the PR is prolonged because the pacemaker tracking. So it can track whatever the based on your fixed AV delay programmed, and it can maintain AV synchrony up to whatever the maximum track rate. So after maximum track rate, if the sinus rate even goes above your maximum track rate, right? So this is what it happens. So this lot of parameters involved here, right? So there is something called TARP, okay? So and which is P warp and AV delay, okay? So so many parameters are involved here, but again, you need to program in such a way. So um, what parameters we need to set and how do we program. So let's say let's see in upcoming slides you will understand. Stop me wherever you have doubts. So maximum track rate, this is what it happens in Venki back phenomenon. So you see it's p waves are followed and then 1:1 conductions maintained and again it skips. So typically you can see the Venki back phenomenon in pacemaker patients.
It's a simple thing. See what he's trying to tell you. You keep it at 65. The patient starts running. So you kept it in such a way that your upper track rate will go up to say 130. What happens if the rate goes more than 130? It abruptly cuts to half. Somebody is going at 130 and then suddenly becomes 60. They'll obviously have syncope. What does our body do to that? It brings it down slowly, brings it down to 70, 80, then 75, then 60. That's what. It's a smoothing. It's a rate smoothing kind of thing. So he's not dropping it immediately. Okay, that's why you're keeping a max track rate, but you're keeping it in such a way that your drop is smoothened. It's a rate smoothing. It doesn't come from 130 to 65, half. It'll come to 100, 90, 80, so that the patient won't drop. It's called as a pacemaker Wenckebach or a pseudo Wenckebach.
So here, as I told you, like you take care of in terms of programming. So there are a lot of other options also, like rate responsive heavy delay and rate responsive PVAR, and so this allows the patient, the Venki back window. So the Venki back window between 2:1 AV, 2:1 block and maximum track rate. So you can create a Venki back window. So in that terms, you have to program a rate responsive AV delay and rate responsive PWAP. So PWAP and AV delay, if you are fixed, okay, so then this problem can happen. But certain parameters, of course, we can understand by looking at the practically. If you go and program the devices, you will understand what set of parameters we can, it will allow you to program, and you need to understand the TARP and all those other parameters. Of course this is important. I'm just touching the topic where it is also can be programmed and also can be taken care in terms of programming. Okay, I'm not going in depth. So complications of pacemaker. So generator failure, battery drain, lead fracture, lead dislodgements, lead infection, and tamponade and myocardial rupture. So this is again just two examples which I gave you. So here you see here typically, yeah, here you see there's a ascent, but there's a P wave and followed by there is a spike, but there is no QRS, which means what is it? The pacemaker has delivered the voltage, but the myocardium is not captured, which means the chamber is not contracted, which probably it is a cardiac uh, loss of capture, loss of capture here. So pacemaker spike we have seen, but there is no QRS, which is loss of capture. Here you see here in the below, this is, I mean, there's no spikes been seen here. Okay, it's all like some noisy, but it is again no spike, which means the pacemaker has sensed something else and it's inhibited pacing. Inhibition means like it's not delivered the impulse. This can happen. Suppose the pacemaker patients are dependent. Suppose dependents on the pacing. Pacemaker patient, doctors may call for any general surgery or thoracic surgery. In that terms they may use electrical cautery and all those things. So in case in those scenario we may have to change more modes. We can change rather DDD mode, we can change to DOO mode, which we call it as asynchronous mode. So whereas if you change it to asynchronous mode, it maintains the rhythm, blindly it will pace. Okay, so we are not the sensing parameter, sensing options we are going to switch off. So this can be this only temporarily during the procedure we have to change the mode settings. Okay, this is again, the question is it a VT? Everybody knows what is arrhythmia, right? Is it a VT? So when you get a rhythm and the ECG like this, but we cannot say it is VT, right? Why we cannot say VT? Because there is a spike, right? And of course, we can understand this patient may have pacemaker and there is a spike. So the pace rhythm, so it's not a VT, right? So again, um, this is one more scenario that we call it as pacemaker mediated tachycardia. So you see the pace. This is also one of the problem with the pacemaker patients with dual chamber pacemaker. So here it abnormally it's like maintains the re-entry tachycardia. Okay, so it's whenever there is a patient has got a retrograde conduction, right? Retrograde conduction to V to A, the AV node when it is allows the conduction goes towards the A, so then it will conduct the impulses can go to the atria and then contract. So this problem will happen for few patients. Few patients will have this phenomenon, that's V to A or retrograde conduction phenomenon. So in those patients, we should be very careful in terms of programming, whereas this pacemaker mediated tachycardia happens. So even at the rest, the pacemaker mediated tachycardia can happen. So let's say the patient comes, it will be symptomatic because we may program maximum track rate at 130, 140, it pays at 130. The atria, the ventricular, it abnormally it will make creates a circuit and it will pace at the maximum at track rate like 130, 140, whatever you program, it goes up to the top maximum track rate and then it will basis. So patient definitely will be symptomatic. And again, here you see why I called it, is it a VT? Because you cannot hear AV synchrony. So there is no AV synchrony here whenever there is a PMT. This is VA conduction. So that is something which abnormally pacemaker has sensed, atrial channel has sensed after the QRS, right? So if you do echo for this patient, you will definitely you cannot see the AV synchrony here. So that is again, it's a problem. So patient, let's say we have given a pacemaker and even a lot of PMT and patient asymptomatic, but PMT is occurring. Those patient definitely comes with a heart failure within 3 months. Within 3 months, patient can get a pacemaker syndrome.
You will be called.
You won't know what to do. He'll call the technician. You're all in the course. You will be called. Yeah, you don't want to hear that you'll be called. Any of you want to hear that you will be called? What will you do? Any of you have been called in such a situation anytime in your hospitals? The doctors don't know what to do. No? Usually first year resident won't know what to do, so he's going to call you. What will you do? Anybody's worked in a setup where EP is going on? Any of you working in a setup where EP is going on? Or pacemakers are being implanted? Nobody? None of you have pacemaker implantation? No? Okay. So that's okay. Wherever you join, no, you'll be called. Okay? So you need to know. That's all. Anyway, sir is going to tell you now. Dr. Anand will tell.
So pacemaker mediated tachycardia, this is oftenly called it is endless loop tachycardia. That's what madam says, like this is endless loop tachycardia. So we have to stop it. So if you don't have anything to stop, then this will be there forever until the patient comes to ER and do something. Some patients I've seen in my career, there are some patients asymptomatic PMT, pacemaker mediated tachycardia. Their heart rate always, at the rate of track rate, maximum track rate, and they are there asymptomatically. After during the follow-up, we found that rate is still sustained due to the PMT. So if the PMT option, there are all the pacemaker, dual chamber pacemaker, they got PMT options. How to stop it? To this is culprits, how it will trigger and how to stop also we know. So we can program every parameters. I'll show you. So, and of course, it occurs when you give a pacemaker, dual chamber pacemaker in DDD mode or VDD mode. Pacemakers will have this problem whenever there is a tracking. So, typically reaching the upper tracking rate limit. That's what I said. Whatever you program track rate, it will be there. So, common causes include premature ventricular contraction. That is called PVC is the most culprit. And of course PVCs will have all the patients, right? So as I told you, the PVC contraction should get into the atria via AV node. The retrograde conduction capability should be there with that particular patient. Then only this PMT can occur. So not all the patient, right? So in those scenario we should be careful during the programming. So long AV interval. So let's say, for example, I'll allow a pacemaker patient to program prolonged PR interval in that to encourage the AV intrinsic conduction. So in that scenario also it happens, and of course retrograde conduction. And so we want to terminate this instant. Let's say remote area patient is in somewhere in the remote area. So the somebody has called you for the it's the patient, this is the scenario, the ECG been sent to you. And in that case, keep a magnet, and it'll the moment you keep a magnet on the device, okay, 10 hours of weight of magnet if you place on the pacemaker, it will turns into asynchronous mode. The mode will be switched DDT to DOO suddenly. So then it will terminate, suppose. That is the only option where we can do without programmer. So terminations can, yes.
No? If you don't know what to do and you are called and you are not sure how to program, take one magnet which will always be there, put it on that pacemaker. Over. That's it. So simple, no? You'll remember this.
Yeah. So PMT termination algorithms in all the pacemakers as we can program. It's a programmable feature. So nominally it is on actually. Somebody turns off, then we can switch it on. And of course, PWARP also can be, we can extend it. And of course, this PWARP, there are so many options, extending the PWARP and after the PVC, and pace after the PVC in atria. So which means that the retrograde conduction can be terminated by having only pace at A after the PVC.
But this
because
doesn't
PVC
hold
is
good
the-
for VT and all, okay? Please remember, it has to be a PMT, only then it will work. If patient is having actual VT, VF, all that, then magnet and all won't help. You have to shock the patient, or you have to, that won't be your part anyways, but that you have to remember. It has to be a PMT, and you're not sure, are you programming the PWARP right or not, then you can use the magnet.
So this is one example, whereas atrial under sensing. So atria has under, see, it's clearly it is sense ESNS V pace, but here there is a P wave, but it's not sensed. After the P wave, there is a spike, atrial spike, which means already P and when atria is contracted. So this is A pace and V pace. So again, here the P, next P might be happened here, and it is tracked and it is gone to the retrograde. Retrogradely it is sensed and it is started, VA conduction here. So this is also one scenario it happens, suppose. So PWARP is one major parameters which we can extend and in those VA conduction patients, and we can program adequately. So and that's all about PMT. And this is device aspects, programmable features like pacing output is important, mode, sensitivity, and pulse width, etc. We need to take key parameters and specific algorithm, pacing avoidance, AF related sleep apnea and auto capture, sudden Bradley response, and also PMT preventive algorithm. So these all key features in the pacemaker which we need to take care of. So there is small case study which is very this is patient came for the intermittent AV block, we have given the pacemaker, and just EF was 50%. And 1 month follow up, we have seen that we fixed AV, since we pace like normal AV delays, And this is what the post implant ECG, the A pace, V pace, and I mean the ECG was good, and the you can see P followed by QRS and atrial pacing and ventricular pacing is happening, but again it's a LBB pattern of the ECG, and this there is no problem again. So the concern is like, if there is a patient AV nodal conduction, so always like we want to minimize the ventricular pacing to avoid this LBB pattern of ECG. So here some parameters you can, if you can adjust, it will help the patient. So post reprogramming with AV optimization, we call it as AV optimization, so which means AV nodal conduction to encourage. So we can we can have this option AV search. There is a VIP. There are so many algorithms which can be used in the pacemakers and allow the AV nodal conduction, natural conduction, encourage native rhythm basically. So so to so unnecessary pacing can be avoided. Electrically achieved significant result with the appropriate program. So which means yes, whatever you use the algorithm programming options, basically we need to achieve the appropriate result. So post AV search, this is post AV search. I saw this patient, and then we could able to see there's no good AV conduction, suppose, and then we paced only atria and then allowed AV nodal conduction. So the beautifully RBP pattern of ECG, and of course this patient unnecessarily, if you pace, may develop and may worsen the EF 50% borderline LV dysfunction, and it may worsen the LV function, suppose. So patient maybe after 1 year or 2 years may develop pacemaker syndrome. So this is best option where we need to take care of. Right time, if you take care of the patient in this by using the algorithms, can be taken care. So important parameters have hemodynamic sequence and impacts percentage of VPACE, and battery life also will improve. Unnecessary pacing, of course, if you avoid it, will battery life also will improve. So default values at 100 to 120 milliseconds sensitivity delay, but we can also give a heavy search on that. So pace delay usually 120 to 200 millisecond, and of course pace delay and sensitivity delay is totally different, and individually we can program. So after sensing, the pacemaker will maintain the AV delay, that is sensitivity delay. After pacing, the pacemaker maintains the pacing in atria I'm talking about, sensing in atria I'm talking about. After for ventricular, it's going to maintain the AV delay. So after I sense, what is the delay I have to, what is the next QRS I need to proceed. So that is where the delay comes here. That is basically we are playing here with the PR interval. Okay. So, and of course we can, if you do can be taken care by pacemaker syndrome. So this is one scenario where unnecessary pacing can be avoided. But of course, if in one more scenario that the AV delay, when you talk about AV delay, so here we can also look into typically one important thing which we need to think. AV delay plays a role for pacemaker patients. Is very important role, because we have given a AV AV synchrony pacemaker. So but you have to maintain appropriate AV synchrony. So here let me give you one example. Suppose problem here, there's a pacemaker patient ECG, dual chamber pacemaker happening here in atria and ventricular. The pacemaker, just assume what is happening in atria, it's pacing.
Is it pacing in the atrium? No. Then is it pacing in the ventricle? Yes. But then is it tracking what is happening in the atrium? Yes. So it is what mode? ASVP. Yes, Anand.
Good. So ASVP is happening. So it's sensing in atria and ventricular spacing. But there is one problem. If you can find out if there is a problem, we are dealing with again here. So heavy delay. So heavy delay, everybody echo C, right? So in echo A to V, what do you see? That AV PR interval, right? PR electrically we are given here ECG. If you do echo for this patient, will you be okay with this? I mean, let's say electrically we are giving the ECG, and what will be the mechanical function here in terms A to V? What is missing here? Anybody guess? So it's almost AV fuse, right? Because look at that, just after the P wave, end of the P wave, there's a pacing spike, which means I have not given time for A to V delay. That there is no segment. Have you seen segment there? There's no segment. So which means I'm early pacing V. This is one of the example, but there are patients who comes with the left atria dilatation patients whoever has the wide P wave. So the wide P wave, and of course the ascents happens in the first part of the P wave, and then probably you might have programmed the AV delay of 130 or 150 millisecond in the pacemaker. So end of the P wave, it will be paced immediately. The QRS will be generated. So it will be AV fused in echo if you mechanical function. So here again, though you give the pacemaker dual chamber asynchronous pacemaker, but AV synchrony pacemaker, but still you are losing that AV synchrony. So this is small parameters which we need to take care here, and this is what we require. Either you pace AV or you AV, but you need to you need to give a PR segment. PR interval is very, very important.
Anand had actually mentioned that somebody was fatigued and tired. You know, why is that so? How does it all this pan out clinically? And you see, why has God given a PR interval? What happens in the PR interval to the ventricle? It fills, right? So if you do not give adequate filling time, after that comes the QRS. That's what it fills and then it ejects. You do not give filling time. If the patient has tachycardia, the filling time, the diastolic filling time is so low. Correct. You need to allow for that much AV delay, that filling should happen. But if the patient has got his own PR interval, that's what he's trying to say. If he's got 150, you could try to keep it at 170 so that the patient's own QRS comes before the paced QRS does. You can save battery life. You allow for the filling to happen. That's what it means by playing with the PR interval. You see what that patient's PR interval is, program it to that. That's why it's called optimization. There's no fixed thing for you and me. You may have a different one, I may have a different one. So for that patient, what is his PR? Keep it a little longer than that. If the patient's native fails, the QRS is anyway there from the pacemaker. Right, Anand? Correct,
Yes,
right?
exactly. So that's what, as sir said, like beyond the routine programming, so you need to take care of patient diagnosis, like diagnostic, like you need to understand the patient basically, like what is his symptoms, why he has come to for the follow-up, regular follow-up or any symptoms present. So all that you need to look into that, and then look at the ECG, and then comes to the interrogate and see what is the percentage pacing and trends and activities, histograms, and any atrial arrhythmias is present, or any alerts, any events. Could be a pacemaker patient can have a VT also naturally. So though any, then doctor can understand is there any cardiac coronary artery disease is present. So all this can be taken care. So the tech has to, being a tech, we have to inform doctor with a enhanced diagnostic tool, by looking at the enhanced diagnostic tool. So just take home points. So understand the patient clinical condition before interrogation. Choose the appropriate algorithm as per the patient condition. Choose the appropriate parameters based on the patient clinical condition. Quality programming brings better outcome. So conclusion, our knowledge of various programming options in pacemakers and matching it to patient's clinical profile can provide patient a huge benefit. Thank you.
Thank you, Anand. See, what he has discussed in 50 slides is probably a lifetime of learning for all of you when you join this thing like his, like you have a Boston Scientific or your Medtronic or Biotronic or whatever. You will need to learn this over a period of time. And then they absorb you slowly and then they teach you on the job. So what is fixed in 20 or whatever 30 slides is completely, kind of a lifetime learning that he has done. Thanks, Anand, so much for that. It was a wonderful talk compressed into 30 or 40 slides. I request Rita ma'am to give him a token of our love and appreciation for his work, not just for today, but also for coming back to our institute and teaching our text, teaching all of us on the job, because how you do this on the job when you put in a pacemaker is best learned with the PSA, what what he's trying to talk. On the PSA, on the, on your pacemaker system analyzer, how do you really time the delays? What do you do? It's something that you learn over time. Don't feel, like discouraged if you didn't understand some of this. Ma'am, can we just give Anand the token of our love and appreciation? Thank you so much, Anand. Year after year, coming back and teaching our students our text. Thank you so much for that. May Swami's blessings be always on all of us. Sairam. Thank you.
Like one of you, right? So you see where people reach in their careers, and this is very encouraging to see a technician. And right from the first talk, I think it's the first talk was initiated by our own technician student. She's now doing MSc. So this program is just here to show that all of you have a very bright career path ahead of you. Okay, but you have to study, and understand a lot of basics. We are skipping one talk in the interest of time. We're already running late. We'll do TMT. Please stick to the time.
Good morning, all. Myself, Dr. Mahesh. I'm third year cardiology resident here. Today, I'm going to present a talk on treadmill test, not just another run of the mill. Actually, in the treadmill test, we are going to test the physical capacity of the patient, like exercise capacity of the patient. Like during test, the heart rate and the stroke volume and the various parameters will change in a patient, like systolic blood pressure and total peripheral vascular resistance. So taking all those parameters into consideration, we are going to look at the patient holistically, and hence we comment on his exercise capacity, and hence we will decide whether patient has any disease or not, like coronary artery disease and etc. So patient assessment, here we will assess patient for any medical diagnosis or past medical histories, such as any pulmonary disease or any arrhythmias in the past, any coronary artery disease like that. And if the patient has any at present any symptoms like any chest pain, ongoing chest pain or anything is there. So if patient has an ongoing chest pain, you should not do a test. So like that, we are going to assess the patient and take him for the further tests. And we'll also look for risk factors such as hypertension, diabetes mellitus, and obesity, dyslipidemia, smoking into consideration. And we'll also ask him for other drug history, and also we'll do brief examination before we take for him for treadmill test. So the patient should not eat for 3 hours before the test, and a routine medication should be taken with small amount of water. Subject should dress in a comfortable clothing and wear comfortable walking shoes or sneakers. The subject or patient should receive a detailed explanation. So taking consent is very important. And we should explain him what we are going to do for him. So treadmill test provides a common form of physiological stress in which subjects are more likely to attain a higher oxygen uptake and peak heart rate than during stationary cycling. So we can do treadmill, either we can stress test the patient. Yeah. We are going, we can test the patient either making him walk on a treadmill, or we can make him stationary, like we can make him, sit in a bicycle and ask him to pedal, or we can make him lie down on a table and make him, push the dumbbells. So there are various tests. So supine also is there, even sitting also is there, and even running also is there. So among these, if you ask me which is better, so walking or running treadmill test is more physiological compared to other forms of testing. So cycling may be preferable when orthopedic or other specific patient characteristics limit treadmill testing. The most frequent used step treadmill protocols are there are various protocols, like the patient should achieve a proper heart rate, and hence he should achieve proper limits to call it as the patient has completed the test successfully. So I'm coming to that. So we have various protocols for that. So in this, we, after explaining the patient everything, we will ask him, we will connect the ECG leads to the patient. So there is one modification in this called as Mason-Likert modification. So we cannot tie the leads over extremities of the patient. So we will make a modification such that the leads will be connected to the nearer to the torso of the patient. So the upper limb leads will be connected here, and the lower limb leads will be attached will be here. So when we do this modification, there are some slight changes in the ECGs, such as right axis shift can be seen, increase in voltage in the inferior leads, and new development of QS in the AVL. So again, this is one more pictorial representation of the Mason-Laken modification. So I told you about the protocols. So we have Bruce protocol, modified Bruce, Norton-Weber, ACIP, modified ACIP, and there is one more protocol called Gardner protocol, which we use in peripheral artery disease patients. So this Bruce protocol involves that the patient will be asked to run on a treadmill, and every 3 minutes the grade of the inclination of the treadmill as well as the speed of the treadmill will be increased. Inclination, then every 3 minutes the inclination will be increased, and hence the speed of the treadmill will also be increased. So sometimes elderly patient will not be able to do start the treadmill test. So we have modified Bruce protocol. In this modified Bruce, we don't give any inclination. We'll just ask them to walk at a 1.7 miles per hour, and hence we'll increase 2.5 miles, 3.4 miles, like that we'll continue. So here you can Bruce protocol. So initially the Bruce protocol had been started at 1.7 with an inclination of 5%. But in the modified, we have this zero inclination part. So like this 1.7, 2.5, 3.4, like this miles per hour will be increased gradually. So during the testing, the patient should be assessed for the any ECG changes, blood pressure, or any symptoms are present in the patient. You should keep checking that. So what are the indications for terminating the exercise test? So there are some absolute indications where you have to stop the test, such as ST segment elevation of more than 1 mm in the leads which don't have Q waves. Like there should be not, you should not take leads which have previous Q waves because of the previous MI, and it should be in the leads other than AVR, AVL, and V1. So if the patient develops drop in BP of more than 10 mmHg while doing the test, and patients experiences moderate to severe angina, and he has central nervous system symptoms such as syncope, dizziness, or walking disability, or patient develops signs of poor perfusion, such as he becomes completely pallor or cyanotic. So and patient has sustained ventricular tachycardia. So mind you, these parameters you need to look at carefully, because this is sustained ventricular tachycardia. If the patient has non-sustained ventricular tachycardia, you can still continue the test, or if he has any VPCs, you can still continue the test. So if you have any technical difficulties, like you cannot measure the ECG or BP, of course, if you can't measure main parameters, then you have to stop the test. So
This is one of the ought to know things in RGHS. Remember, as in life, this, no, go back one.
Yes.
You should know all of this, okay? And you should know it properly and why it happens. It basically means that your LV is not able to take the load of exercise. That means the LV is getting ischemic. The patient is not able to perfuse. The patient is not having CNS blood supply adequately. He's having angina. There's a drop in pressures. Essentially means the same. So this is in RGHS always, and we are encouraged to put this question. At least learn it for that, okay? You have to know absolute indications to stop a TMT. TMT is your bread and butter. You're supposed to know everything in TMT. But this is absolutely, yeah, go on, sorry.
as I told you, if there is drop in BP of more than 10
Go ahead,
mmHg,
go ahead. What is your
if
what your
with the
relative
symptom,
contact?
it is absolute indications to stop the test, or if there is no symptom with the drop in more than 10 mmHg, then it is a relative indication. Okay. So if there is marked ST depletion, displacement such as more than 2 mm, fatigue, shortness of breath, increasing chest pain, arrhythmias, I told you, if there is multifocal ectopy, ventricular triplets, supraventricular tachycardia, those are not absolute indications. These are relative indications. Okay. Exaggerated hypertensive response, like patient, anyway, BP will rise during the testing. If it rises more than 250 mmHg systolic and more than 115 mmHg diastolic, then this is a relative indication to stop the treadmill testing. And if patient develops any bundle branch blocks, such as left bundle branch block, is important. So analysis, coming to the clinical response. So patient develops any severe chest pain or moderate to severe angina, we will stop the test. Or a patient has any same or similar chest pain, like patient tells in the past he had sudden severe chest pain. If it is similar to that, we will stop the test. So coming to the exercise-induced angina is an important clinical predictor of the presence and severity of the coronary artery disease, equal to or greater than ST segment depression. So patient symptom is very important, or as equal as important as ST changes you see in the ECG. consideration of limiting versus non-limiting chest pain is important. And we have one score called as Duke treadmill score. I will come to that. So hemodynamic responses. If in hemodynamic responses, we will see at the heart rate and BP responses. In the heart rate, the patient should reach a maximum heart rate of 220 minus H. This is the formula we give. Like if the patient doesn't have any ECG changes, if the patient can do complete test, then till what time the patient should do the test. So this will give, this heart rate formula will give till if the patient reaches this amount of heart rate. Like for example, if there is a 50 years of age patient is there, 220 minus 50, so 170. If he reaches 170 beats per minute of heart rate and is able to do continuously the test, then you can stop the test and tell that the patient is has negative for the indivisible ischemia. So submaximal study is utilized submaximal study when the patient does not reach the assigned peak heart rate and it is below the age predicted heart rate also. And if referred to as inadequate study when the patient fails to reach the pre-defined goal, such as 85% of the age predicted maximal heart rate. So this is the absolute value and this is in the percentage. So if a patient without known coronary artery disease has an inadequate study, the term non-diagnostic study is often preferred. Yes, ma'am. Yes, ma'am.
In submaximal, if you have an age predicted, it is 70% of that minimum to be achieved.
Yes, sir.
So it's 170 is what you said, 70% of.
Yes, sir. So, in the presence of any other diagnosis, like I told you, if the patient develops any changes in the ECG or any symptoms, so there is no rule that you should reach the age predicted heart rate threshold. So, coming to chronotropic.
What if you reach it too early?
Sir,
What if you reach it too early? That's called physical deconditioning.
physical decongestion.
If the patient is not conditioned to exercise, sedentary people and all,
Yes.
so they might just start to get heart rate rises very fast, even before you've reached the second or the third stage. So there's no way you can evaluate anything.
Yes, sir.
So that's physical deconditioning where the patient is not conditioned to doing it. It's a patient, right? I mean, he may not be as, like he's not an athlete.
Yes, sir.
So any of us could have it, actually. We may be physically deconditioned. Second or third stage, we might reach our APMHR, whatever, or whatever, 85% of that. It's not interpretable then. Correct. That's called physical deconditioning.
Yes, sir. Coming to chronotropic incompetence, so this is one parameter where inability of the heart to increase its rate to meet the demand placed on it. That is, we calculate this chronotropic index. According to this chronotropic index, if the patient cannot reach this parameter, then this is an independent predictor of cardiac or all-cause mortality. So failure to achieve a chronotropic index higher than 80% defines the presence of chronotropic incompetence. If the patient is on beta blocker, as we all know, if the patient is on beta blocker, it will reduce the heart rate, the threshold will be lesser. So if the patient not able to reach the 62% of the index that we have calculated, then it means the patient has chronotropic incompetence. Coming to heart rate recovery, this is one more important parameter. So after the patient stops the treadmill and he rests for at 1 minute, if the heartbeat does not reduce more than 12 beats per minute from the maximal rate he has achieved, then it signifies the patient has some inherent coronary artery. So it is defined as less than 12 beats per minute after 1 minute with post-exercise cool down and less than 18 beats per minute after 1 minute with immediate cessation. So this is after making the patient sit down or immediately after the patient stops the test. So, and either less than 42 beats per minute after 2 minutes. This suggests there is abnormal heart rate recovery. It is associated with increased all-cause mortality in both asymptomatic individuals and patients with established heart disease.
What is it essentially showing you? Anyone? All this is there in books, but did you understand what it means? It just shows poor vagal tone. When you exercise, right? When you do a lot of exercise, your vagal tone goes up. The whole point of meditation is that you're trying to build your vagal tone. And when your vagal tone is high, it'll get down your heart rate faster. Go ahead.
Yes. Coming to blood pressure responses. So systolic blood pressure, pulse pressure, heart rate, and a blood pressure product like double product. Double product is nothing but heart rate into SBP. So the actually double product, if you multiply the heart rate to the systolic blood pressure, if the patient does not cross the value of 20,000, then we call it as patient has some inherent disease and we should do the further testing. Okay. So in most normal subjects, systolic blood pressure will increase to higher than 140 mmHg and the double product to higher than 20,000. Coming to exaggerated systolic pressure response, that is, I told you, greater than 210 mmHg in men and greater than 190 mmHg in women. If even though these exercise responses are considered abnormal, they are not generally reasons to terminate the exercise. So up to 250 of systolic and 115 of diastolic, you can wait. So coming to exercise-induced hypotension, it is defined as systolic pressure during exercise falling below resting systolic pressure. That is 20 mmHg fall after an initial rise. So either of these definitions would be an absolute reason to terminate the exercise test, and it is more predictive of poor prognosis and is usually related to severe multivessel coronary artery disease with left ventricular dysfunction. So coming to the abnormal ECG responses, so we have three abnormal ECG responses. One is ST segment depression, horizontal ST segment depression, and slow ST segment uprise. So if the patient has rapid upsloping, usually that is a normal response. If the patient has, so when do you see, at what point you have to see the ST segment depression or means downsloping or horizontal? So after the J point, after that 80 milliseconds. So 80 milliseconds after the J point, you should check for the ST segment downsloping depression or horizontal depression. So ST segment depression 0.1 millivolt or greater and the ST segment slope is within the range of 1 millivolt per second. This signifies there is significant coronary artery disease or other diseases which should be tested. So anyway, ST segment elevation happens means it is an ischemic, severe ischemic response, which the test should be stopped and the patient should be taken off for the testing. Coming to the lead AVR, usually previously it was told that more than 1 mm ST segment elevation in lead AVR is not significant, but emerging literature suggests that 1 mm or greater ST segment elevation in a lead AVR is significant predictor of left main disease, proximal LAD disease, or multivessel coronary artery disease. So I told you there is one test like Duke treadmill score, that is exercise duration in minutes and which is subtracted with the ST segment deviation multiplied with 5 and the angina index. So angina index has 0, 1, 2 score. Like 0 means no pain, 1 is patient has pain but he is able to complete the test, 2 is patient has the pain and he has stopped the testing. So we categorize this score into 3 groups: more than or equal to 5, -10 to -4, or less than or equal to -11. So it gives the probability of the stenosis and the multivessel disease, also the probability of 1 year mortality. So higher Duke treadmill score is suggestive of higher risk. Coming to the arrhythmias during the exercise. So exercise-induced arrhythmias, we have approximately 1/3 of individuals without heart disease can also have ventricular ectopies. So main arrhythmias, I will come to that. If the patient develops exercise-induced atrial fibrillation, so there is an evidence that patient who have developed exercise-induced arrhythmias, they have higher probability of coronary, higher burden of coronary artery disease, and hence we need to further evaluate the patient. So as you can see, patient has sinus rhythm. As the patient goes on testing from B to D, you can see the RR interval varies, means the AF has developed. Coming to the premature ventricular beats, last 2-3 seconds. So during exercise testing, 7 or more PVCs per minute occurs at some stage in normal individuals also. If the patient develops multifocal VPCs, then that is more suggestive of some sinister etiology, underlying etiology, and we need to do further testing. So if the patient develops left bundle branch block, so there is something called as a rate related bundle branch block. So if the patient develops left bundle branch block at lower rates, such as less than or equal to 120 beats per minute, then it is suggestive of increased risk of coronary artery disease. So you have to look for bundle branch blocks also. Does the patient develop right bundle branch block? Yes, he can develop. So it is also suggestive of like incidence is 0.24%, and it is also suggestive of future coronary artery disease, heart failure, and development of hypertension. So coming to the exercise-induced VT, anyway, the VT development of VT is suggestive of underlying coronary, significant coronary artery disease, and hence further testing for the anatomical stenosis there or not. If the patient develops complete heart block, this phenomenon is associated with an increased risk of subsequent syncope in the future, and the AV blocks are also suggestive of significant poor prognosis in the future. So this is one of the example I wanted to tell, but because of short of time, I want to complete that my talk. Thank you.
If you're all in posted in the TMT lab, no, then keep one manual or something next to you. Reasons to start, reasons to terminate, absolute, relative. If you keep going through it, no, you will find it much easier in the future. We did this as doctors, so it's important that all of you also do the same thing.
Thank you, sir, for adding a great clinical perspective. We now break for tea and refreshment. I would like to request all the students to be back as soon as possible.
Small announcement, all the delegates who have checked in through the app, please don't forget to check out before you leave so that it will help us to give a e-certificate. Thank you. Sai Ram.
Where is the tea being served? Outside onto the left. I think you all need it also. Sugars are coming down. Please rejoin ASAP. We're going to have very senior faculty now. Satish sir is already here. Dr. Sola is on the way. Sola sir has reached. He's on the way, and then we'll have this. Please come back ASAP. Fifteen minutes max, please. Thank you.
What would you tell a man who can scroll for hours?
You too.
ప్రేమ స్వరూపులారా, ది బెస్ట్ వే టు లవ్ గాడ్ ఈజ్ టు లవ్ ఆల్, సర్వ్ ఆల్. మనం అందరినీ ప్రేమించాలి, అందరినీ సేవించాలి. మనం సేవించడం కోసమని పుట్టాము. ఈ సర్వీస్ లో మనం ప్రయాణమైనప్పుడే మానవత్వం అనేటువంటిది సార్థకం అవుతుంది.
तेरी इतनी हंसी के इनका आशिक मैं बन गया हूँ। मुझको बसा ले इनमें तू। इनका आशिक मैं बन गया हूँ। मुझको बसा ले इनमें तू। मुझसे ये हर घड़ी मेरा दिल कहे तुम ही हो उसकी आरज़ू। मुझसे ये हर घड़ी मेरे लब कहें तेरी ही हो सब गुफ्तगू। बात तेरी इतनी हंसी मैं याद इनको जब करता हूँ। फूलों से आए खुशबू। रख लूं छुपा के मैं कहीं तुझको, साया भी तेरा ना मैं दूं। आँख तेरी आँख तेरी इतनी हंसी के इनका आशिक मैं बन गया हूँ। मुझको बसा ले इनमें तू। के इनका आशिक मैं बन गया हूँ। मुझको बसा ले इनमें तू। मुझसे ये हर घड़ी मेरा दिल कहे तुम ही हो उसकी आरज़ू। मुझसे ये हर घड़ी मेरे लब कहें तेरी ही हो सब गुफ्तगू।
Girls, give a call outside.
बातें तेरी
Call them inside.
इतनी हंसी मैं याद इनको
Go off the music. Get the patient.
जब कर
We have to squeeze stocks. Come on, call them back. Get the patient here, please. You could switch off this light. Mandira, if it's getting late, ask them to take the tea. Come back inside. You won't waste time. Get them inside and they can have it here. Can we switch on the splitter, please? Can we switch on the images as she's doing it? Try it. Right now, do it.
You want to see the person who's standing near the podium?
What?
Podium.
No, this is good enough. Who's talking? She's having it in the hand. She'll use this. Okay, fine. Two of you. Can we start the talk, please? Jayashri? Jayashri will speak on the ultrasound physics, ecoviews and knobology. We'll try to be brief. She's our BSc Tech from here, and now she is in second year of MSc. And this is one topic which will come as your short notes. It might come as your 5 markers. And in life, you need to know your ecoviews well. So please try to be brief and to the point. Thank you. Yeah, we can start. We'll have the other students join in, please, ASAP. Go ahead.
Good morning and greetings to everyone. Today I'm going to give a brief presentation on ultrasound physics, echo views, and the knobology. I'll be covering the important basic concepts of ultrasound, the piezoelectric principle, instrumentation, ultrasound modes, knobology, and basic echocardiography views practically there with their importance. Coming to what is ultrasound, about the introduction. Ultrasound refers to the sound wave with a frequency greater than 20,000 hertz. That is really beyond the range of human hearing. In the medical imaging, we use high frequency sound waves, usually between 2 to 10 megahertz, to visualize internal body structures. The ultrasound probes send the sound waves into the body. The waves get reflected back to the tissues. Then the machine processes these returning echoes to create an image. Ultrasound is widely used because it is non-invasive, radiation-free, and usually used for the diagnostic purpose, especially in the field of cardiology as an echocardiography. Coming to the piezoelectric principle, it is a basic working principle of the ultrasound. When certain crystals are exposed to electrical energy, they vibrate and produce an ultrasound waves. Similarly, when returning echoes strike the crystal, they generate electrical signals. These crystals are present inside the transducer, what we call as probe, and commonly used crystals are quartz and lead zirconate titanate. So basically, the probe converts electrical energy into the mechanical energy during the sound transmission and mechanical energy back into the electrical energy during the echo reception. This principle helps in generation and reception of ultrasound waves for the image formation. Coming to the ultrasound instrumentation, the components are transmitter, transducer, receiver and processor, display, and the storage device. A short on everything. Transmitter controls the pulse rate and energy levels sent by the transducer, where transducer is a converter, where it uses the piezoelectric crystals to turn the electrical signals into sound waves, and vice versa. Receiver and processor captures the weak returning echoes and clean them up. Display, it converts process signals into visual formats, that is your 2D grayscale imaging or the Doppler. Disk storage, it saves the images and also the videos for your review and records. Coming to the transducer anatomy, the important used things are active element, that is the piezoelectric crystals, backing layer, which shortens the pulse for better imaging, matching layer, which increases the sound transmission into the body, and the acoustic lens, which focuses the beam. So here is the transducer and its arrangement. Coming to the imaging mode, we know, as you all know, there are three types of mode, that is A mode, B mode, and M mode. A mode is the amplitude mode, where it visualizes as the spikes on the graph, where it is amplitude versus depth, and it is rarely used and it is one-dimensional. Till today, now it is not used much, but it is used in the Department of Ophthalmology, sometimes in these days. Coming to the B mode, that is brightness mode or the 2D echo mode, where it is visualized as the grayscale 2D image. Mechanism, echoes appear as dots, and brightness depends upon the signal strength. Coming to the M mode is the tracking mode, tracking the moving structures over time. It is depth versus time. It is having good temporal resolution, which helps in measuring the fast moving heart valves or the chamber walls. Coming to the Doppler modes, as we know, it is continuous wave Doppler, pulse wave Doppler, color Doppler, and tissue Doppler imaging. These all modes are basically dependent on the Doppler effect, where it measures the change in the frequency of the sound waves, reflecting the movement of the blood cells in a tissue. Coming to the pulse wave Doppler, it is used for measuring blood flow velocities at the specific location, where pulse wave sends an impulse and it waits for it to return back. Where continuous wave Doppler, it is used to measure the high velocities, such as across the stenotic areas. Advantage, there is no aliasing, but there is the limitation of pulse wave Doppler is aliasing. Continuous wave Doppler, it can measure very fast flows accurately, but the disadvantages of continuous wave Doppler is it lacks the range resolution because it takes the beam all over the line. Coming to the color Doppler, visualizing the flow direction and patterns. Rule BART, that is blue away, red towards. Red indicates the flow towards the transducer, where blue indicates the flow away the transducer. Coming to the tissue Doppler imaging. It is used in measuring the velocities of the myocardium, that is the heart muscle rather than blood. Coming to the clinical evaluation, it is essential for assessing the diastolic function and the myocardial function. Coming to the knobology, what is
So the
knobology?
basic idea, what she's trying to tell is the blood flow patterns. I know you know all this, but just as a refresher, the blood flow patterns are in the chamber or in a vessel, while tissue Doppler is in the tissue. It's in the myocardial tissue. So it will have a different flow pattern here, for example. This is myocardial inside the myocardium. Septum, she's kept it there. Septal and lateral. You can mention that when you come. Yeah, go on.
Coming to the knobology. Knobology, why is knobology important? Knobology is actually important to optimize the image. Knobology refers to the manipulation of the machine controls to achieve the best possible image that we could get. Coming to the gain. Gain is the overall brightness. Function, how is gain used? It adjusts the amplification of the returning echoes throughout entire the image. When the gain is too high, very white, as they are showing practically. Is too low, the image becomes too dark, where it is difficult to distinguish few structures. Coming to the goal of gain, the balanced grayscale, where fluid is black and tissue is distinct with shades of gray. Coming to the next one, that is depth. Depth is field of view. Adjusting the depth adjusts how deep into the body the ultrasound machine looks. ROI, region of interest, is always keep the heart or specific structure centered on the screen. Usually the goal of depth is the structure of interest should occupy 75 to 80% of the screen. Coming to the next, time gain compensation. It adjusts the brightness at specific depths rather than the whole edge. Disadvantages, sound loses energy and there will be attenuation happening, and it travels very deeper, the bottom of the image darkers than the top. Ideally, TGC slider should be diagonal in slope from top to bottom.
Stay on the image. Stay on the image. What is there in this image? Guys, we gave you tea and snacks and everything. Now at least tell us. Anybody? Loudly. So what is area dilated? What do you think this is? Yes. Now what I want you to see is first degree AV block. Whenever you're doing an echo, your eyes should be on the ECG, not just on your image. You see there is a first degree AV block. There's a PR interval that's prolonged. And that happens because the RA is stretched out. You should be careful in this guy to put a device, because your device might impinge and actually increase the AV block. Or even in a surgical case. You see there is a huge difference. I think this is a PR prolongation here. We can see the exact thing, but you see how big the PR segment is and PR interval is. But be always mindful that the image is also a human being. Anyway, yeah, go on.
Coming to the next knobology.
Of course, there's an ASD. There is an ASD, sorry. Yeah.
That is sector width. It adjusts the horizontal angle or the width of the ultrasound beam.
You have the TGC, you have a camera on that? No? Huh?
No,
Okay, fine. So there's those, those buttons from top to bottom. That's the TGC on the screen. It's okay, doesn't matter. It's okay, go on.
Here it is on the slide, sir.
Slides are there?
On the slide. Right.
It's okay, doesn't matter. Go ahead, go ahead.
Coming to the sector width, narrow the sector, fewer scan lines and needed for the frame. Increase in the frame rate, providing better temporal resolution. And the wide sector width provides larger field of view but slows down the frame rate. So use the narrowest sector as possible that still continues your region of interest.
There are other things that you can make out in this. All these are subtleties. You see, there is a deep S in that ECG. It's probably lead 2, right? It's lead 2. S in lead 2 is not common. That means there's an RBBB in this patient. Why is there an S in a left-sided lead? 2 is towards the left. It's 1, 2, 3, right? So probably you have an RBBB there. All these things should come to you when you're doing the ECG echo. I'm not saying this is an echo class. Imagine again, this is a human being, right? You need to see all of that. Is there an RBBB on the ECG? See it later. Okay, go on. RS R prime, no. I'm talking of lead 2 showing an S. Why is the lead 2 showing an S? Integrate your echo and ECG. That's all I'm trying to tell you. Go on, go on, go on.
Coming to the focus, it narrows the ultrasound beam at the specific depth to maximize the image detail. The benefit of focus is it improves the lateral resolution in the ability to distinguish two structures. Anybody could tell what is lateral resolution? Axial resolution, lateral resolution. Lateral resolution, it could distinguish the structures side by side. Where the placement of the focus should always be at the region of interest or the area of interest what we want to look through. That may be the LV for the function of LV, where for the mitral valve, if we want to focus on the mitral valve for the prolapse or any stenosis kind of things, any mitral valve pathology. Coming to the color Doppler settings, it controls the sensitivity, adjusts to fill the vessel while according to the color bleed. The important thing in color is color scale, that is PRF. It controls the velocity direction. It increase for fast flow to prevent aliasing, decrease for slow flow, picks up the signal. So you need to make it optimal, not too high, not too low.
Not too wide, not too narrow. Not too wide, not too narrow. As you make it narrower, obviously your scale will go up on the top right.
Even the Nyquist limit scale, you need to put it in your range.
Do not interrogate regurgitation less than 60 or 70 Nyquist limit. It will not be correct. Always. Always keep your Nyquist limits correct, typically when you are seeing MR or TR.
So as Sir told, the box size controls the processing, where small box size increases the frame rate and better real-time imaging. The other thing is dynamic range. Dynamic range manages the gray shades displayed on the screen. Coming to the high dynamic range, more shades of gray resulting in the softer image. With low dynamic range, we are having few gray shades and more black or white image. Frame rate, critical for capturing the moving structures. You directly can't change the frame rate, right? So what are the other things which we use to change the frame rate? Other changes which impact the frame rate? Anybody? Yeah, sector width and depth. Even the depth is also a factor that could change your frame rate. Coming to the frequency. Frequency is the important feature of ultrasound. I just kept about the frequency, not much into detail. Because frequency is used, it is an important factor to check the probe which we want to use. You need to differentiate what is the Hertz probe used for the pediatrics and adults. High frequency, less penetration, better resolution, and good image. Low frequency, better penetration, less resolution, and reduced image contrast. So these are the few probes with their frequencies, which we use in the Department of Cardiology. Coming to the types of probes, there are a lot number of probes, but these are the 4 probes which we see in our everyday life. That is linear transducer, which we use for the vascular ultrasound, phased array transducer, which we use for our usual cardiac echoes, which helps to, which it is made to fit into the ribs. And this is a curvilinear probe for the fetal echoes, and a esophageal transducer for your TEs.
Your current RGHS format also requires that peripheral should be learnt in third year, right? Even MSc. It's important for you to know all this.
Somebody could tell how is this all differentiated, why it is called linear, why it is called phased array. It is based on crystal arrangement. Yeah, this is the same thing. This is we use phased array transducer because it is having a very small footprint and used for cardiac imaging. Coming to the probe orientation, the marker direction is crucial for the correct anatomy. Standard echo views: parasternal view, apical view, subcostal view, suprasternal view, right apical window, and right parasternal window. Somebody could actually finish it fast by telling what are the structures you see in a plaques and what is used, what do you assess from each view. So the structures you see in plaques are LV.
It's like most of them know this, but it's a refresher.
LA, LV, mitral valve, aortic valve, IVS, and posterior wall, RVOT. It is mainly used for your LV function, mitral and aortic assessment in adults. When you're coming to the pediatrics, you will see a VSD when it is a perimembranous VSD on your plaques. And
What
the
do you
patient-
not see? Apex.
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 Coming to the parasternal short axis view, just rotate your probe from your plaques towards 90 degrees. We are having four levels in parasternal short axis, that is aortic level, mitral level, papillary muscle level, and apex. The uses of short axis is it is better to assess the regional wall motion abnormality, RV assessment, because you have a PA, and RVOT seen in your aortic. Even you could look for your bicuspid, unicuspid aortic valves also.
PDs.
Coming to the apical fourth chamber, the marker should be towards left, towards the apex. The structures you see are RA, RV, LA, LV. It is used for mitral and tricuspid valves assessment and defects across IAS and IVS. Uses, it is used for the chamber comparison, EF estimation, and Doppler measurements. Coming to the apical five-chamber view, just tilt or angulate your probe anteriorly upwards from the position of fourth chamber. The structures you could see is LVOT and the aortic valve clearly. It is used for associating flow across the aortic valve and calculate the stroke volume or cardiac output via Doppler. Coming to the apical two-chamber view, we can clearly stick to two chambers, that is LA and LV. What is a clinical value to it is it visualizes the anterior and inferior walls of the LV, which is essential to detect the wall motion abnormality. Coming to the apical three-chamber view, it is actually plaques from the apex. It is used to visualize the LVOT and aortic valve from a different angle for Doppler measurements. Subcostal view, just probe is placed on the sternum, angulated up towards the heart. It is best for clinically ill patients to check for pericardial effusion in adults, but that is the gold standard for pediatrics. Suprasternal view, where the probe is placed on the notch above the sternum. Focus is the right arch and its branches. It is used for detecting the aortic coarctation or any arch pathologies. Last but not the least, the take-home message: always start your echo with plaques for adults and subcostal in patients. Optimize your image before any measurement. Parallel to the flow, that is according to the Doppler effect. Use multiple views before concluding. Never rely on one single parameter. Last but not the least, if you're not getting a good window, ask the patient to breathe out, hold, and acquire your image. Thank you. Sai Ram.
Thank you, Didi. That was a clear and practical introduction to cardiac imaging. Now, I ask the Institute of Health Sciences to brief us on the most important clinical application of echocardiography in ischemic heart disease.
On behalf of all the students, I welcome sir again. Sir is part of our extended family, Satyasai family always. And just one request from us, and sir is always ready to take classes for students. Wonderful teacher, learned a lot from him. I have, ma'am, and he's always been a part of Satyasai group. Thank you, sir, for coming here again. I also welcome Shola sir here. Shola sir is here. Yeah, Saram sir. Thank you so much, sir. I just request not to flash, lights if you're taking any snap. You can take it, but it disturbs the speaker. So thank you so much.
Sairam to all of you, and it's always a pleasure. Dr. Rita and Dr. Prayag, I think I've never missed over the last few years. I think whatever it is, I try to sort of make it a point to come, and it's a pleasure to meet Dr. Srikanth after a long time. So coming to the topic here, so this is the bread and butter of Echo, if I have to use that word, and this is something which you have to know in and out. Wherever you work in India or even abroad, you have to deal with this. So I'm just going to take you through a little bit of anatomy and the imaging part of it. The terminologies we use: ischemic heart disease, coronary heart disease. These are the ones, the abbreviations are there. And I'm going to spend some time here, so you have to look at the anatomy, these pictures which you see even online also. You have to spend time. So once you have this picture in your mind, then it is easier to understand the anatomy, supply, and then the wall motion becomes a lot more easier. So just to sort of go through, so let's take only the chambers first. So you have the left ventricle on this side, and then you have the right ventricle. And this is something which I have created very crudely. So this is like a wall over there. So that is the interventricular septum. And you have the anteroseptum and on this side, and you have the infroseptum on this side. And on the front part, this is the anterior wall. And then on the other side, you have the lateral wall and the posterior wall, which comes there. And here you have the RV, and then you have the inferior wall of the LV comes on this side. So you have the orientation in terms of the structures and then the surface. Then I will bring in the arteries here. So you have the left coronary artery. So you have the left main over there. And then as it comes down, it branches into the circumflex as the left anterior descending, the LAD, and then into the septum, the perforators, and then as it goes down, it gives branches to the diagonals, to the anterior wall, and then the circumflex goes on to the other side and gives branches, it supplies the lateral wall and the posterior wall over there, while the right coronary artery comes from this side, and then it gives an early branch to the right ventricle and then to the inferior wall. So that's the sort of to look at the anatomy and the supply part of it. Then when we use the word regional wall motion abnormalities, different institutions, different way of expressing it. So you can have RWMA, you can have WMA, and then people also use segmental abnormalities. So what causes RWMA? Commonly it is CAD, and then you also have non-CAD causes. So you have a few examples of myocarditis, stress cardiomyopathy, and then infiltrative cardiomyopathy, some certain types. And when we use the word RWMA, we usually imply in our report that it means CAD. And when we say global hypokinesia, we say it is non-CAD. But it can happen the other way in a small percentage. So sometimes global hypokinesia, you can have a multivessel disease, and what you perceive as small, sort of subtle wall motion can be termed as global hypokinesia. But generally, when you say RWMA in your report, you're trying to tell that what you've seen is related to CAD. Then let's look at the views. So you have the anteroseptum in the long axis, and the posterior, the infrolateral, and then you have the supply here. So you have the LAD for the anteroseptum, and then you have the circumflex for the infrolateral or the posterior wall. And then you have the long axis, and in the long axis, it's no different from your personal long axis or the three-chamber apical long axis or the apical three-chamber view. It is similar to the personal long axis. The only difference is in personal long axis, you don't get to see the true apex, but in the apical long axis, you get to see the apex. So that's the only difference. Otherwise, rest is all the same. And then the apical four-chamber comes, and then you have the infroseptum here, and then you have the anterolateral or the lateral wall. And then here again, you have the LAD distally, and then you have the RCA proximally, and then you have the circumflex on the lateral side. And then the two-chamber views. So you have the RCA, the inferior wall, and the anterolateral, the lateral wall. And then for the anterolateral lateral, you have the diagonal, the LAD, and then you have the RCA for the inferior wall. So you have 6 walls, 6 distributions, and then you can look at the supply, territorial supply in this perspective. So if I have to sum everything together, so everything you look at in terms of the apical 3-chamber or the long axis view, and then you have the 4-chamber and the 2-chamber. So typically it's about 6 walls, and then you need to know each wall, which artery supplies which area. Then let's look at the short axis, what is called as commonly the bullseye. So once you get the short axis, a quick look at it gives you an understanding if there's a wall motion, which vessel to a large extent by echo we can define. So this part is the part of the septum over there. The top part of the septum is the anteroseptum, and then the anterior wall comes on this side. So this is the LAD here. And then as you go more laterally, you have the lateral wall on this side, and then you posterior wall. So this is where the circumflex comes. And then you come to the surface below. So this is the inferior wall, and then the septum, the lower part of the septum is the infroseptum. So this is where the RCA supplies. So a quick look at it, and you know a good sort of idea of what you're dealing with. And this is something called as the bullseye. So everything sort of put together. So the outer segments are the basal segments, and then you have the mid segments, and then you have the apical segments. So you look at the AAC 16 segments, you have this blue spot, nothing is termed over there because that is the apical cap, and apical cap is very difficult to see because it hardly moves. But once you brought in sort of the perfusion in terms of the myocardial contrast, then the apex started to be seen by echo also. That's when it got integrated, and then there was a common terminology. So either you can use the AAC, or more often now the AHA 17 segments is used, which with slightly different terminologies, where you have the anterolateral and the infrolateral, and then you have the apex, which is different from the AAC 16 segments. Now, when you look at the RWMA, you look at first and foremost, what are you looking at? Number of segments involved. And then you decide whether it is hyperkinetic, akinetic, or dyskinetic. And then look at the thickness. Is it preserved thickness? Is there partial thickness? Or is it thin? So that means it gives you an amount of ischemia that is happening, amount of the myocardial infarction or the necrosis that has happened. And then look at the distribution. So is it a basal segment? So it is proximal. Or if it's a mid and apical segment, so then it could be a distal lesion. And is it a single vessel? So if it's just in the territory of LAD, it's single vessel, or if it is more than that. And then also look at the RV, especially when there is an inferior wall MI. And then, just a pictorial representation of how the thickness looks like. So you have the partial thickness, partial infarction, and then you have the complete transmural infarction, and where you're going to get a scar over there. So this is again hypokinesia, akinesia, and dyskinesia, how you look at it. So thinning means anything less than 6 millimeters, you start to say that it is thin. Now, when you're doing the echo, you have to make sure that you get a good endocardial border definition. So that means the inner lining, the inner layer should be clearly seen. So maybe sometimes you might want to increase the gain a little bit. So then you'll see the endocardial border better in terms of the wall motion. So you understand the wall motion better. So when you have something like this, you can see that the lower image, you barely see the left, the lateral wall over there. So use the gain judiciously whenever you don't see the endocardium nicely. Then you have to look at how you acquire the 4-chamber view. So when you have an apex which is very pointed, where you have a very long length of the LV, and the apex doesn't move that much, so this is going to be the true apex and the good 4-chamber view. When you have a rounded apex and there's a lot of movement at the LV apex, that means it's not a true apex, that means it's foreshortening. And if you get something like this, then your acquisition is wrong. So then you have to go one space lower down and try to get the image which is shown above. Short axis, try to get a good image in the sense that the cavity should be circular. So the more circular the cavity, the more correct cut you're taking. And if you have an oval shaped cavity, that means you're not in the true short axis, and that means you're going a little off axis. So try to do the correction and sort of try and get the patient more steep left lateral and see if you can get the short axis better. And when you're looking for any myocardial thickening, primarily you're looking for thickening here. Use the knobs which are available on the machine. So slow the cine speed and see in slow motion whether the thickening is happening nicely. Sometimes you have paradoxical movements, so like LBBB, post-cardiac surgery, and then pulmonary hypertension and other causes. So where you mistakenly think it is wall motion, so be careful. When you're saying RWMA in terms of CAD, it has to be two adjoining segments in a territorial distribution, and then it is related to CAD. And for you, if in case if the opposite wall is normal and if you feel that the other wall is abnormal, compare both walls. So you have a good comparison of a normal wall, and then you decide whether it is hypokinetic or akinetic. And always try to look at the ECG, always make it a point, never look at a wall motion in isolation. So look at the ECG, look at the symptoms, look at the clinical profile of the patient, a young person, 25 with no comorbids, and you give a wall motion, then there is, relook at, you'll have to find out whether it is really wall motion or not. And make sure that you store good images. So this is an era where images are being archived and being retrieved. So you would like to look at comparisons later on when something new has happened and you want to go back to it. So apart from the wall motion, so in CAD you also look at the LV systolic function. So look at the do it in the correct way as much as possible, biplane LVEF. Visually EF, I know that a lot of you still do it and you continue to do it, but try and avoid it as much as possible, especially when it is in the borderline area. Do the biplane EF, and that is the correct way of doing it. And when there is a CAD and then you have decreased LVF, more likely there are a lot of segments involved. So more segments involved, the LV function starts to come down. And more akinesia, then likely the LVEF is going to come down. What is the role of tissue Doppler in CAD? Very minimal. So you see these systolic velocities, the positive velocities, the velocity which are seen above the baseline. So they have limited value. So use it with caution, and lower velocities less than 5 centimeters are supposed to be abnormal, but use it carefully, and don't be sort of over enthusiastic, and don't over diagnose. So limited use, and use it with caution. Speckle echo, again, we have these wonderful pictures. Not all patients provide these nice images where you get the territorial distribution. So it has got sort of moderate sort of value in terms of the yield, and not very entirely sort of reliable. So be careful when you're doing it. So don't jump to conclusions. It may be a bad window, or you might have done it improperly. So the speckle, also use it with caution. And if you have access to contrast, use the contrast to find out how the wall motion it comes out better. So in terms of looking at the endocardial border definition, so that sort of gives you more information. 3D in terms of CAD, you can use it for the LVEF, and you want to look at some areas in terms of wall motion, looking at the slices, and then you can also look at any clots over there. So that is where 3D can help you, the multi-slice or the I-slice. And also a lot of importance for diastolic dysfunction. So anytime you have CAD, especially whatever the type, acute or chronic CAD, so look at the diastolic dysfunction. So here you have a grade 1, so that means that this patient is going to do well. But when you have a CAD patient with grade 2 or a grade 3, that means that this patient will have more events, will have a lot of problems. So it's your sort of responsibility to give in the report what you've seen and do it correctly, and use the tissue Doppler to give a correct diagnosis of the grading of what the diastolic dysfunction is. And also at the same time, calculate the E by E prime and give the LV filling pressure as per the standard recommendation. And the PA pressure also usually correlates with the higher the E by E prime, more likely the PA pressure is going to go up. Now, looking at a different area of CADs, looking at mechanical complications. So a few complications, they usually come in a symptomatic way, sometimes in a very dramatic fashion. It can be in this ICCU, it can be in the triage, and patients come with a lot of distress. So this is one example of papillary muscle rupture. So usually there is an MR which is eccentric, and when you look closely at the papillary muscle, you'll see that there is a distortion of the anatomy. You see something which is moving, mobile, and this is a partial papillary muscle rupture. You can also have a complete rupture, which is even more dramatic. So this is one complication, MR papillary muscle rupture. And then you have the ventricular septal rupture. So these also patients who come with similar sort of presentation, and typically after the MI, and you have a thinned area, and then you have the rupture, which can be at the apical or it can be at the lower, depending on which artery is involved. And there is an acute thinning over there, it gives way, and then you can have a single defect or you can have multiple defects. And for this, you have to go a little off axis. So not all ventricular septal ruptures are seen very nicely with good views. So go a little off axis and try to pick up these ventricular septal ruptures. And also look at the RV size and function, and then especially in the basal BSR, look at the MR also. So that also has an important role in management. Then you have an even worse sort of scenario. So you'll suddenly be called, patient is collapsed, and then you have this free wall rupture, there'll be effusion. So typically, patient who has sort of collapse, and then you have effusion, the suspicion is usually a free wall rupture. And you can see the free wall rupture typically occurs somewhere in the area of the lateral wall or at the apex, and you can have a dramatic sort of outcome. So you can have sudden death, or you can have a free wall rupture, and the below image shows a large thrombus which is sitting over there, and temporarily it has sealed the rupture, and this patient will have enough time to sort of survive for a little more, for more, for management. So you can have patients coming with a large thrombus and with a temporarily sealed free wall rupture which has happened. And you have the aneurysms. So there are two types of aneurysms. You have the pseudoaneurysm, and you can see that there is a break in the wall over there. So there is no continuity at all. So the break is called as a neck. So that is a very narrow neck, and you have this outpoaching over there. So anytime you see a narrow neck and you have a aneurysmal outpoaching, so that means it's a pseudoaneurysm, and look for a thrombus. And this is again compared to the true aneurysm. So this is a bit of a more of an emergency or something urgently which has to be tended to. So you have to inform the clinician if you've seen it at the earliest. True aneurysms take a longer time. So, and then you have, there's no breach in continuity of the wall, and you have thinning over there, and you have this large neck over there. So here you have a very wide neck. So that's the difference between true and pseudoaneurysm. And again, look for any thrombus over there, and where exactly is it located. Then you have inferior wall MIs. So inferior wall MIs, again, they will come with a sudden drop in BP, and then you can have ECG changes also. So you can see that the RV is dilated here, RV is not contracting, and then there'll be TR. So that is the inferior wall MI with RV MI. So that again is an emergency which you have to sort of identify and then get it across to the clinician. Any pericardial effusion, especially in acute coronary syndrome, treat it very carefully and bring it to the attention and identify it. And typically we would like to know why it has happened, and we have to, there are various causes for it. So that is again another area where we look into what is the etiology for the pericardial effusion. Then you have LV thrombus. So this thrombus, first is you can have a spontaneous echo contrast. So anytime you have an area where it is akinetic, where it is not moving, so that is a place where the thrombus forms, and some people tend to form acutely. And before that, you get to see these, the smoke or the spontaneous echo contrast. So increase the gain a little bit and see if it is there. And if it is there, look closely for whether there's a clot. And if it is no clot, but it continues to be there, there's a likelihood a clot can happen. So keep looking at it all the time whenever the patient comes for follow-up or for your echo. So here you can see that the apex has got a layered clot. And if you're not alert enough, you will think that is actually the wall of the LV. So be careful about it. So that is an LV apical layered clot. The clots can come in with different ways. And here you can see the top one is the dyskinetic LV apex with a layered clot, and then you have a very huge thrombus. It's, this, nobody will ever miss it, and very dramatic, very nice to look at, but very sort of a high risk for the patient for embolization. And anything which is mobile, you have to immediately bring it to the attention of the clinician and tell them that there's a mobile clot, because this clot can break and get into the arteries or in the brain and cause a problem. You can sort of go off axis and look at it. So you can see that I've gone a little off axis here, and also do the short axis and try to get to see the clot better. And sometimes clots cannot be easily seen, the layered clots, and then you can push contrast and you can see the dark area at the apex. So that's where the contrast is. So anytime when you see some dark area, because clot typically doesn't take any bubbles, so that is going to be the thrombus over there. So a few points before I sort of wind up. So wall thickness. So anytime you have a wall motion, look carefully at the wall and write it in your report whether the wall thickness is preserved or there is some thinning. So you can see that the image below, there's a little bit of thinning in the distal infroseptum over there. So that indicates that there is some non-viable tissue over there. And then anything bright which you see over there, you can see that the septum has got a very bright area. So here the muscle has gone and there's a lot of fibrous tissue. So that is a scarred area. So it can be the entire wall can be scarred, or it can be part of the wall itself which will be scarred. And you can see the one image below. So part of it is scarred and part of it is there's still some amount of muscle over there. So scar tissue, bright tissue. And then look at the LV remodeling also. So the LV also changes its shape in different ways. So you can see that the top image shows the LV is has got a very funny shape. The short axis has become very wide, so that means it's not a good remodeling. And you can see the one below, so there is dyssynchronous LV, so and you have a minor axis almost beginning to equal the long axis, so this is like a globular LV. So if you are smart enough and sharp enough, you can identify especially the lower one, a dyssynchronous LV, and then the thinning over there, and then the globular shape, that will help. And be careful of the walls. So some of the walls, especially the lateral wall, you can have lung artifacts and you may not see it. And you might want to sort of go slightly off axis and take a look at it. So sometimes to hold the expiration, and then you can see it much better. So lateral wall has got its own problems. And then inferior wall also has got its own problems. You can see that next to the inferior wall, you have the diaphragm. So diaphragm sometimes holds the inferior wall a few milliseconds, and that sort of lag in the movement, sort of you might think there is a wall motion. So be very careful. It's a common problem. It's widely known that the inferior wall, you can sort of tend to over-diagnose. Actually, there won't be any wall motion, but you think there is a wall motion because of this. So be careful of the wall motion, and correlate it much better when you're looking at it in terms of trying to come to a conclusion. And again, just like lateral wall, in anterior wall also can be hidden by the lungs. So post-interventions, so if you're called, patient has undergone a PCI, and then what are you going to look at? Look at the LVEF, has it improved, has it worsened? Has there been a new RWMA? Has it improved over there? And see the angio report and look at what they have done and try to correlate. Look at the MR, has it worsened? Has it improved? And more importantly, look at pericardial effusion, and is there any signs of tamponade? Typically, you'll be called when there's a sudden change in the patient clinical status. And when you're in the surgical ITU, so look for any chamber compression due to pericardial effusion. So it's a common immediate post-operative, and then any clots there, and also look at the PA pressure. And in follow-up, so patients keep coming to you, so look for any previous MIs, look for true aneurysms, and aneurysm has been forming. It was not there earlier. Now the patient has come with aneurysm. Look at it. Look at the thrombus, whether it is there, especially in akinetic area or an aneurysmal area. Look at wall thinning, scarring, report that. Any change in RWMA, improvement, worsening, extension, again mentioned. Severity of MR, has it increased, has it improved? Good for the patient, has it worsened, not good for the patient? LV size and shape, as I told you, LVEF worsening or not, LV diastolic dysfunction grading you have to mention, RV size, has it improved, TR severity, and the post-interventions in terms of PCI and CABG. So the other, just a few small points is there's some terminology called as ischemic MR. So typically here, you can see that the posterior wall is akinetic, and because of that, the papillary muscle attached there has been pulled. It's holding back, and then the PML gets pulled back and it gets restricted, and that causes the MR. And here in ischemic MR, you usually see the MR posterolateral jet, and that's a very characteristic feature of the ischemic MR. And then coronary artery imaging, not so easy. So, but whenever you see some coronary arteries very nicely, so spend time, look at it, so understand it much better. And it's always fun when you get to see some good coronary arteries sometimes, especially the anomalous ones when you see it. And then when you ask for T, so when you want to look at the etiology sometimes of the VSR, MR, or when they're poor echo windows, you look at the T. So to conclude, a few sort of points in terms of echo in CAD, where can echo be used? So you'll be looking at triage, you'll be looking at the CCU, you'll be looking at interventions, cath lab OT, looking at the cold patients, the ward patients, and then follow-up patients. And how are you going to use it? Use your regular conventional echo, and when you want to do advanced echo, so you know the limitations and the advantages of each one of them and choose and find out. And then you have the T and stress echoes, which are a little higher. So again, that's left to the consultant in charge to sort of take an opinion on that. And while imaging for CAD is a summary of whatever I said. So is there RWMA? And when you see RWMA, how many segments are involved? So with this, you conclude, is it single vessel, double vessel, or multivessel disease? Location of the RWMA, could it be a proximal or a distal lesion? Is it hypoekinesia, dyskinesia? Is it thin or preserved thickness? Is it scarred, aneurysmal, dilated? And if there is SEC, likely for a thrombus to happen. And is it, if the thrombus is there, is it a fresh thrombus or an organized thrombus? And the LV function, what is the LVEF, use biplane, and what is the LV size and the index size, and then you follow up, and the severity of diastolic dysfunction, and compare old reports. That's always helpful over there. And this is just a summary of all the mechanical complications. And this is a table which is available in all the books, and you should know each one of these complications, and you should be ready when you face them, and know how to sort of monitor and look at the hemodynamics also. Thank you. So if there are any questions, I will take. So if there are no questions, I will, shall I? I will now move on to a totally different topic. So it's entirely, so it's at the other end of the spectrum. So CAD is very common, 3D is upcoming, and now part of your, it's for your practice, it's going to be there for during our practice, it was an option, but for your practice in future, most of the institutions have 3D and they expect you to know 3D, and you should have some awareness of how to do it, and it's mandatory. So I'll just touch briefly on a few points about the basics. So the difference is that you see that the top one in black and white and the one below, so you have a dramatic sort of difference between the two of them. So you have a 2D image on one side and you have a 3D image on one side, and they look entirely different. It's always the 3D which is sort of aesthetically, and you want to see it that way, and then it has its own pluses and minuses over there. So when you're looking at 3D, so you have when you say 2D, you have the height and width. And when you have depth added to it, suddenly it becomes a 3D. And when it is a frozen image, so it's going to be 3D. And when it starts to move and it's in real time, so it is either called as real-time 3D, or some people call it as 4D. So that's the terminology. So we sort of just know some very basic things about what is 2D and what is 3D. And again, in a pictorial way, so you can see that we've all seen cartoons. So we started from this era where it was just a single sort of 2D type, flat image. And then the depth was put in, suddenly it started to look good. And now, it's getting better and better. So this is how it is, we are seeing it in all spheres of life in different contexts. So the first question is, do we do 3D for all patients? No. So there are some specific areas. So we still not reached the stage where 3D is the default. So we still have a lot of use for 2D. 2D will be there for a long time. So there is a time and place for 3D. So look at the chamber function. So look at all the chambers, how much of EF volumes you're going to look at. LV mass can be looked at. Structural viewing. So each one of the valves can be looked at it in different ways. You can look at the septae, the interatrial septum, the ventricular septum. And then you can look at it in congenital and then in structural abnormalities, and also for color in terms of what is called as the vena contracta area, and then the origin of the lesion. And you have 3D in TT, you have 3D in T, and also intracardiac echo. So this is just for basic knowledge. And when you're going to use it, you're going to diagnose something by 3D, and you're going to use it to support some interventional procedures, and also for monitoring certain type of patients. So that is where the help or 3D help is going to be there. So the question is how to do 3D. So some of you might already be sort of looking into it. So first and foremost, you have to make a decision as to what structure are you looking at. You just can't say that I'm going to do 3D and not knowing what you're going to do. So have clarity there, what structure you're going to look at, what is that you're trying to find out. And that is when things get to be a little more focused. So either the chambers, valves, septae, or something else. And which view you're going to look at, which is optimal view and which is the recommended view. And once you've decided, then you look at the image and see if the image is good. So good 2D image usually translates into good 3D image. And then adjust the frequency. So the frequency also plays a big part in getting good images. And then adjust the depth. You don't want too much of depth and too big a sector width. So again, you lose out on the clarity of the image. So these are some very basic things which you have to know for a good ECG image. And then it's usually better to have ECG gating. That means you have to have an ECG connected, put on the patient, and try to look for a good R or a QRS wave so that your acquisition becomes better. Some of the newer vendors, the newer software provides 3D without the ECG also. That is the present day. And very importantly, spend time on the anatomy. And unless you understand the anatomy, you have to go back to the anatomical books, and then each one of the structures has got its own anatomy. If you don't know the anatomy, then you won't know what you're looking for and what you're seeing. So it's going to be a big problem. So whether it is the valve or whether it's the wall or septum, whatever it is, and from which side, so know your anatomy, very, very important. And spend time with the machine. So I always keep telling that, the best friend for you is the machine, and unless you sort of know how to develop a relationship with the machine, you're always going to have a problem. So know the machine in and out, know your knobs, and especially in terms of the 3D, there are a lot of knobs which are there, and these are the knobs which are commonly sort of used, and know each and every one of them and what the value they bring in, when to use it. So spend time. Unless you spend time with the knobs, then it's going to be a longer learning curve. You will learn, but it takes a longer time, and you will be lost for a longer period, I would say. Terminologies. So there is something called as azimuth plane. You can see that the beam is moving side to side. So that means it is trying to capture image from whatever data is there from side to side. So that is called as the azimuth plane. And here you can see that it is going from top to bottom. So it is capturing image from up and down. So this is called as the elevation plane. So these are knobs which are available, and they have the same names on that. And you have to be familiar with it. And when it comes to the image, you can see that the blue line is what is called as the lateral or the azimuth sort of data set. And then you have the white, which is the elevation over there. So that is how you correlate with what the probe does and what the image you see over there. The 3D probe is got a lot of crystals, so it's more expensive. It doesn't last that long, so use it with a lot of respect and care. And it's that's because a lot of engineering has happened. A lot of crystals are there, and you can see that it can rotate in whatever direction, and it can give you images. That's the principle of it. Very, very basic sort of picture of how the 3D sort of works. The 3D probe works. Now, there are different ways of doing a 3D. So the first and foremost is any 3D probe will have something called as a biplane or X-plane. X-plane is used by the Philips machine, and the biplane is used by the GE and the other vendors. And use this because what you see is your reference image. This is your baseline image over there. And then you have the short axis, which is orthogonal or the 90-degree image to this. So it gives you simultaneous images, 90 degrees to each other. So that is called the biplane over there. And this again is an example of what a biplane is. So you have at 0 degrees a 4-chamber, and at 90 degrees it gives you a 2-chamber. So you can get infinite cuts and in infinite ways. So, but when you say orthogonal, one is at 0, the other one is at 90 degrees. And the same thing you can do for color also. You can exactly sort of put the cursor over there, and the short axis will tell you where that jet is coming from. So the mode, again, you have the 2D mode and the real-time 3D full volume. So I'll come to that now. And then you have the zoom also. So before that, so make sure that your quality of 2D image is good. So that is dependent on the quality of the 3D image. And when we are looking at the 3D image, we typically say that it is a volumetric data or a pyramidal data. So it's a volume, and you can see that it's a shape like a pyramid. And so you have this volume rate or the frame rate. So in 3D, it's called as a volume rate. And you have this temporal resolution, and then you have the spatial resolution. So the size of volume is that you increase the size of the sector width, and automatically the volume rate comes down. That means the spatial resolution also comes down over there. Now, in a narrow angle, so everything is very small and sort of in a small area, and you have a very good volume rate over there. The images are nicely seen, and it's real time. So it is used only when you want to sort of cursorily look for something which is wrong over there, and then you just want to have a glance as to what that structure is giving you, and it's got great resolution. But if you want to look at something very close, then use a zoomed image. So here it provides a very focused, and typically just like a zoom in 2D, it's the same thing. So you just zoom it up, and this option is there, and this is used widely. So you know how to use a zoomed image. It's got its own sort of value, and you should be aware of it. And then you, apart from the real-time 3D and then the zoomed image, now it is a full volume. So that means the real-time 3D was just in a small area where you're looking at it, and the zoomed was even more focused. But in a full volume, what happens is you can take the entire 4-chamber and then you can look at it. So that means more work for the probe. That means it takes a longer time. So that means the quality of the image will not be so good, and the volume rate also comes down. So it's a sacrifice. You want to see everything, but the spatial resolution comes down. So these are, again, in a very simple way, I'm saying what is the advantages and disadvantages. You want everything to be seen because it's something which you have to see, but you lose out a little bit on the volume rate. And then you want to look at 3D also in terms of color. So you put on the color, and again, the volume rate comes down, but the present day machines have really remarkably have improved in terms of the volume rate. So earlier we had very low volume rates because it has more additional work for the probe to do. And again, it has its own sort of knobs, and you will have to utilize it in a way which you want to see where the pathology is. So this is another option. And in terms of I think I will skip this. Let me come to the next one. So you have let's say that you have a very sort of wide full volume image. Your volume rate is very low, and you're not happy with the image quality, and then you want to see you want to have a better image quality. So what you saw earlier was a single beat. Now what you will do is you will utilize something called as a multi-beat. Every machine has got this. So that means it takes in a single, full volume, what the probe does is it takes the entire sort of the heart like this in one go. And because of that, longer time, lower frame rate, and then the image quality comes down. But when you use a multi-beat, what happens is it takes repeated sort of small sections over there. And you can see that there are 4 sort of sections which are taken at immediate at the same time, and they are all joined together, and that image is provided to you. So this is called as multi-beat. So this is, you get good resolution, and you get a better frame rate to the volume rate over there. But there is something called a stitch artifacts, because these boxes over there which you see, they are sort of joined together. So if there is a movement in the patient or something which your hand moves, so then you have a stitch artifact. So this is how the stitching happens. You can see that one image taken here, and then it keeps acquiring images bit by bit, and then finally you get a full image. And if there is any movement in you, you'll get these lines over there, and they sort of look very jerky, not very nice to look at. So those are known as stitch artifacts in multi-beat. And this again, you can see that there's a crack in the 3D sort of thing. It's not really a true pathology over there. That's because it has been taken as multi-beat. So I'm telling you the advantages and disadvantages. So be careful how you sort of look at it and how you acquire it. And then there is another mode which is there in all the 3D machines. So this is called as a slice. So this is a reverse of what you saw. So you take a 3D and then you try to get sections of 2D images. So you try to sort of reverse engineer, and then you can have a different level, small slices at different levels, and then you see what the pathology is. So this is called as a slice mode of it. And there is another type of imaging. So this is known as the MPR, or the multiplane reconstruction. So you have 2 longitudinal axes, or orthogonal to each other, and then you have a short axis. They're combined, and it gives you 3 sets of images from 3 different angles, and you come to a conclusion for whatever reason you want to look at it. So this is called as MPR, a little more difficult and more advanced. So be aware, but in the learning point, you keep it to the last. This is not so easy, and it takes time for you to understand. But if you have to get to this goal, when you have more experience with basic 3D. And then you have these knobs called as dual imaging. So anytime you want to see one, you have an image and you want to see the other side of it, so one front and back, so you just switch to the dual imaging. It gives you simultaneous view of the reverse side of the image. So you can look at a valve from the left atrial side, for example, the mitral valve, from the left atrial side, the ventricular side. So this is the dual imaging part of it. Terminologies. So not so important, but again, just for general knowledge, you should know. So when you see something like this, so it's called as a volume rendered image. And when you see in the middle one, this is known as the surface rendered. And then, of course, the slice is what is the slice rendering image. So a very basic tip. So if the 2D echo is not good, your 3D is never going to be good. So be careful about it. So there's no magic in 3D where it can automatically convert anything, even on a bad window also, it will not be good in 3D. So be very aware of it. So bad 2D, bad 3D. And image optimization. So when you acquire, so make sure that you don't overgain. So when you overgain, you lose depth and you have a lot of blurring over there. You don't see the structure so carefully. So this is a classic example of overgaining it. And when you decrease the gain a little bit, what happens is, or even, no, not just a little bit, even more. So you see a lot of structures are now lost. So it looks as though there is a lot of holes within the left ventricle and then in the left atrium. So that is undergaining. So that means you have overdone the gain with this. So you have these echo dropouts. So these are all optimization where you have to use your gain knob very judiciously. And when an optimized gain, you combine both the TGC as well as the other overall gain, and you have to play around with some knobs like the compression and the dynamic range. So ideally it's about 45, 50, but that again is a knob which you look at it later. So how to optimize the image, you should be aware of it. Then when you have too wide a sector width, so you see that you're wasting space over there. So the image on the other extremes, on either end of the image, has got no value. But for if you do that, that means you're sacrificing the quality of the image because of your carelessness, and there's no value in the sides of the image where you don't get to see anything. So optimize it. So sector width, optimize it as much as possible, and focus the image or the structure which you really want to see. Sector width plays a big role in terms of getting a good volume rate. And cropping is something which is inherent. Cropping is something like, it's a common way of slicing. So you just take a 3D and you keep on slicing, and you slice to a point where you really want to see something which is interest of to you. So that is called as a cropping, and cropping tools are available. It's getting better and better now. So you have a lot of intelligent cropping that is available. You can see that this is the original image, and you go on cropping, and from the side or from the front, and ultimately you end up seeing only this much here. So use the cropping for us. It has its lot of value, and again, it is inherent to your 3D. So you have to spend a little time. So this is a little bit of a challenge for you. So it'll take time, but this is part of the 3D itself. And then you have these wonderful images which are available now from various vendors. So you have the common 3D image over there, which is the gold bronze view. And then you have the photorealistic, because they look real, almost like a true tissue. So that is what is called as the photorealistic image, or the trans illumination. There's a light source, and the tissue texture changes, and you can look at the anatomy much better. So it has got a lot of value, and in terms of how you're looking at the pathology and for various reasons. So utilize this. So this, again, a lot of these vendors are bringing it. And there's something called as glass imaging. So less utility, but where you can increase the transparency. And then again, the photorealistic images, when you put on the color, it looks much, much better. So utilize this whenever you are sort of using color. And even in the glass image, again, limited utility. So this again is an option for the high-end 3D image. These are available in the high-end 3D machines only. And then for routine views, you always use the long axis, zoom views, 4 chambers. So these are sort of recommended views. You can start like this, and then you work around the, optimize the image, and then you do whether you want to do zoom or the multi-bit, you decide, and then you do the cropping, and then you decide what is that you're trying to look at. And in terms of viewing, so you can look at it transversely. So you can see that this is the coronal here, and then you have a transverse section. So you can look at it from different views, different sides. So this is the reverse side of the 4-chamber here, the dual image. And this again, the transverse view again, for looking at it from both the sides, the atrial side as well as the ventricular side. So get this familiar. So this is going to be very commonly utilized, and better the image, better your understanding of what's happening over there. And so this is just, and then again, the same thing, you can see that you can look at it from both the sides here. And what are the various ways of looking at it? So in terms of the EF, very widely used. First thing is know how to do the 3D EF. So that's the most basic of all, and it is now very sort of recommended that you utilize it. So there are various ways to do it, and as long as the image is good, then the way you do it is going to be the output is going to be accurate, and the less you spend time on doing some adjustments, more accurate is it going to be. Unless there's some gross change and gross corrections, try not to do some fine corrections. So usually most of the time the machine does it for you because now it's all AI over there. So again, you have these various vendors, they are getting it better and better. So you have this now the multi-beat EF also from one of the other vendors over there. And so it is again, emphasizing that 3DF is where it's going to be. And also you have 3D RV quantification, less sort of used, more difficult and not so easy in terms of the image quality. So, but again, it is validated, it is recommended. So if you have a good image and if there's a need for it, do it, and you will get some good values. And again, different ways of doing it, and if you do it in the correct way, it's almost comparable to the MRI in the right way. So now they've even gone to the extent of giving you quantification volumes of all the chambers. So now you have all chambers volumes, and that is again something which is of value. And again, along with this, you get the strain also with these present day machines. So this is again knowledge for you. So 3D strain, whether it's used in clinical routine, no. It has still not come into the mainstream utility, but it is available to you, and it's up to you to use it for whatever context in future. And then you have these valve quantifications. Use the explain of the biplane, especially for mitral stenosis, where your valve orifices varying, complex orifices as a routine. So this is where you should start your 3D. Use it in the most basic way. Use the biplane and use it for mitral stenosis orifice area, and that's where you'll start to get the familiarity. So use the biplane as much as possible, then your understanding of the next stage or in different the modes of 3D will get better. So again, different examples of how the mitral valve looks like in long axis, and from the short axis, I mean the fourth chamber also as a transverse view. And then you have the aortic valve. So you utilize the biplane imaging, and the aortic valve, again, looking at it from different views. So just examples of, how you can look at it in different ways. So transthoracic image quality is not as good as the T. And again, tricuspid also, you can take a look at it. And then septum. So, whether there's any VSDs, if the image is good. And atrial septum, ASDs can be seen, but not so very reliable in terms of the dropout. So be careful, but at least to some extent, you can make out these VSDs and ASDs. So, what I would say is that in the present scenario, the machines are much smarter, much better. So 3D is not so difficult. So TT is where you're going to start. The yield is much less. Great imaging window. Utilize it as much as possible. The real value, especially for the clinical, the doctors, is that T is where the real value is. There's also 3D available in the intracardiac echo, and it's widely used over there. And the clinical applications are expanding. So just to sum up, so in terms of 3D, what you're going to learn, so get used to the terminology, spend time, know your knobs, spend more time at the machines. So even if it's a stored image, you can always come back and work on it. That's called as post-processing. You don't have to wait for a 3D image to come to you. Acquire it anytime later, you can do it, and acquire it in different modes. Then you'll know each mode, how it works, and learn during acquisition how to optimize the image, and know the various artifacts. And once you store something inside with artifacts, very difficult. So that means the patient is gone and you're stuck with an image. So be careful. And you should know when to use it and what to use in terms of different pathologies and different anatomy. Thank you.
Thank you, sir, for sharing valuable insight on 3D echo and ischemic heart disease. Now I would like to invite Dr. Rita Varyani, ma'am, to hand over a moment to Satish Govind.
Can I ask Sola sir to join, ma'am, please? Sir, please. Thank you, Satish sir, for the wonderful talk. Takes a lifetime of learning to actually learn 3D. All of us are learning. Thank you, sir. Thank you for initiating us into this and our text. I think that 1 hour was complete. The entire thing that sir has probably trained himself and trained all of us over it. Takes a long time to learn, but I think the last slide was very important. It's a fight in our minds that 3D is difficult, really. It's not so difficult if we start doing it every day for our routine practice. Arun, we'll have your talk now. We have Dr. Arun from Jaydeba. He had to prepone his talk. There is for him to be required like back at Jaydeba. And I thank Sola sir also for stepping in graciously. We'll have Sola sir's talks after this back to back. We'll have echo in RHD. Arun, thank you so much. If anybody has any questions for Satish sir, open house. I think another thing that sort of gets carried on with what Dr. Satish sir is saying is something which Sola sir will discuss after this. That is when you talk about CAD, echo in CAD, it's also important to learn about viability and the need to tell the surgeon or the cardiologist that a certain segment is going to respond to revascularization or not, which is why we had the DAC talk after this. So I want you all to correlate in your own mind the talk about which ACS talk that Satish sir gave with what is coming next, that is about dobutamine stress echo and again for viability and valves today. We'll have Arun's talk on echo in RHD, following which we'll have Sola sir's talks back to back. Thank you, Arun, for being with us.
Good afternoon, everyone. I would like to thanks for giving this opportunity. So we'll discuss about echo in rheumatic heart disease. So as you all know, whenever we are doing echo for valvular heart diseases, we usually go with this sequence. We usually start with parasternal long axis view to look for, this is the left atrium, mitral valve, left ventricle, then the aortic valve, and this is the ascending aorta, and this one is the RVOT. So we look for any mitral valve pathology and aortic valve pathology in this particular view. Then we go for parasternal short axis view, which we have to look at multiple levels. So at basal level, we will see the aortic valve. Then also we look for the chambers. This is the LA. This one is the interatrial septum. This one is the right atrium. Here comes the tricuspid valve. Then comes the right ventricle. Then the RVOT. And with the slight modification in the tilt, we can see the pulmonary valve also here. And the pulmonary arteries comes. A slight modification in the tilt will be required to see that. Then coming on to the at mitral valve level, when we take the parasternal long short axis view, we can see the mitral valve. Here we can see that the in this video, the mitral valves, the commissures are fused. This is a classical image of fish mouth appearance of the mitral valve due to mitral stenosis. And then we go for apical 4-chamber view, wherein we can see this is the left atrium, left ventricle, this is the mitral valve, and this side comes the right atrium, right ventricle. Here we can see severe MR and severe TR. So, and then in the same apical 4-chamber view with a slight tilt, we can get the apical 5-chamber view, wherein we can see we can open the aortic valve and look for aortic stenosis or aortic regurgitation. And then we look at subcostal view to look for IVC, whether it is dilated and how is the collapsibility with the respiration that we see, and then the suprasternal view. So this is a sequence how we do the echo in any case of suspected valvular heart disease. Now, why we should do echo in RHD? These are the things which we should look for. That is valve anatomy, severity, coexisting other valvular lesion, chamber dilatation, hypertrophy, ventricular function, because that is one of the important determinant of when to send the patient for surgery. Then pulmonary artery pressure, aortic root, dilatation, and LA clot. So as we all know, the most common valve affected in rheumatic heart disease is mitral stenosis, is mitral valve, and the pathology will be usually mitral stenosis. So to just a brief note on mitral valve apparatus. So as we all know, normal mitral valve orifice is 4 to 6 centimeters square. So it has got 2 leaflets, anterior and posterior mitral leaflet. Is the pointer visible? Pointer is visible, no? So this is the anterior mitral leaflet, this is the posterior mitral leaflet, this is the medial commissure, this is the lateral commissure, this is the medial commissure. Then we have got the papillary muscles. This is the chorda tendineae, papillary muscles, then LV free wall. These are the various components of the mitral valve apparatus. So mitral stenosis in rheumatic heart disease is, so mitral stenosis in 98 to 99% of the times it is due to rheumatic etiology. Only 1 to 2% can be due to other causes like congenital mitral stenosis or mitral annular calcification, or it can be radiation related. So that is quite rare. So most of the time it is due to rheumatic heart disease. And in rheumatic heart disease, the mitral stenosis is predominantly because of commissural fusion. That is the most common mechanism. Apart from there, it can be due to cuspal fusion, caudal fusion, or it can be combined. So what are the findings which we commonly see in whenever we see mitral stenosis? We commonly see the restricted mobility of the PML, the dooming of the anterior mitral leaflet. This dooming of the anterior mitral leaflet commonly occurs because of the commissural fusion. Rheumatic heart disease, the process starts at the commissures, hence the commissures are the first one to get affected, and it will be because of that we get the fish mouth appearance which we see in the parasternal short axis view. So here we can see both medial commissure and lateral commissures are fused. Medial commissure is fused, here lateral is open. So when usually both the commissures gets fused. Then apart from that, what we see is there is narrowing of the mitral valve orifice. Then apart from that, in the apical four chamber view, you can also see the submitral disease that is better appreciated in the apical four chamber view. Wherein we can see the submitral disease like chordae thickening and get fusion of the chordae. All these things we can find out. Coming on to the mitral valve orifice area, this is very important because this is the best way to assess the severity of MS. It is the most accurate non-invasive assessment of the severity. It best correlates with the mitral valve area measured on the explanted view. So here we can see this has to be taken in the parasternal short axis view at the mitral valve level. We have to go to the tip. We have to sweep from apex to the base, and at the smallest orifice we have to measure in the mid-systole. If the patient is in atrial fibrillation, then we have to take the average of 5 cycles. And the gain setting should be appropriate with a low gain setting. Then the other method to assess the severity is by looking for the transmitral gradient. So mean mitral valve gradient we usually measure. It is the most reliable, but not the best because it depends upon other factors like heart rate, cardiac output, and associated MR. If the heart rate is high, then we'll get falsely high gradient. As the heart rate increases, there will be exponential increase in the gradient. Suppose the gradient is 6, mean gradient if it is 6 at the heart rate of 60, if the heart rate becomes 120, then it becomes 4 times increase. So the gradient from 6, it will become 24. So when the heart rate doubles, the gradient will increase by 4 times. So that's why we have to always assess the mitral valve gradient with the heart rate controlled. If the patient is in AF with fast ventricular rate, we usually advise to reassess the gradient once the heart rate gets controlled. Then and also it depends on the cardiac output and associated MR. If the patient is in atrial fibrillation, we have to take the average of the 5 cycles. Then coming on to the assessing the severity of MS. So we have mild MS, moderate, and severe MS. So mild is based on the gradient. If it is less than 5, mild. 5 to 10 is moderate. More than 10 millimeters of mercury is severe. And based on the mitral valve orifice area. So if it is more than 1.5, we call it as mild. 1 to 1.5 is moderate, and less than 1 centimeter square is severe. Then another method we use is pressure half time. This is the time required for the jet velocity to reduce by 50%. It is obtained by tracing the deceleration slope. In the machine, there will be a pressure half time option. So we have to select that and trace the deceleration slope of the E wave. So mitral valve area can be calculated by using pressure half time. It is 220 divided by pressure half time gives the mitral valve orifice area. It correlates reasonably well with the mitral valve orifice area in the absence of MR and other valvular pathology. So if there is other valvular disease, then it will not be reliable. It depends on heart rate, flow, and the LV compliance. So echocardiographically, so what are the criteria to summarize about MS? What are the criteria for calling it as severe MS? So on this mitral valve orifice area less than 1.5 as per ACC AHA guidelines. But in Indian population, because of our body surface area, we usually take it as American Academy of Echocardiogram guidelines, that is less than 1 centimeter square has a severe MS. Then Doppler pressure half time. of more than 220 millimeters second is a criteria for severe MS, and mean gradient more than 10 with the heart rate controlled. And PASB of more than 50 millimeters of mercury are the criteria for calling it as a severe MS. So apart from that, then we have to look for the suitability for balloon mitral valvotomy. Whenever we diagnose mitral MS, we need to comment about suitability for severe MS. So most commonly used method is Wilkins score, and the components of Wilkins score are: one is leaflet thickening, leaflet mobility, then leaflet calcification, and submitral disease. These are the components. We have to look at all these things and assess the Wilkins score. And if the score is less than 8, it is usually considered suitable. More than 12, it is usually considered as not suitable. 8 to 12, it depends upon, it is like a high risk procedure. Sometimes we can consider. And apart from that, there are other scores like Cormier score, commissural calcium score, and Reed's index. And also we have to look for the presence of LA clot, LA or LA appendage clot, or SEC, that is spontaneous echogenic contrast. If these are there, then there will be high risk of having embolism during PTMC. And we usually avoid if there is a LE body clot. So here we can see what is seen. There is in the it is a apical fourth chamber view. We can see there is a submitral disease. Mitral orifice is narrowed. There is severe MS. Here we can see a dense sac in the left atrium body. And here we get the LA appendage. Here in this view, it is not really seen. If we tilt and adjust the view, you can get the LA appendage also. Also, we have to look for the interatrial septum. Here we can see the interatrial septum here. And if there is a bulge in the interatrial septum, all these things we need to comment in the echo because these are important while doing PTMC. And associated tricuspid valve disease also we can see here. So patient also has got a tricuspid stenosis and regurgitation. Leaflets are not co-opting. Leaflet mobility is restricted. Tricuspid valve, those things we need to comment. And coming on to LA clot, this is one of the common findings in the patient with mitral stenosis. As LA gets dilated, and there will be stasis of blood flow, especially if there is atrial fibrillation. In these patients, there can be LA appendage clot or LA body clot. Here we can see the clot over the interatrial septum. Here we can see the clot in the LA roof protruding to the body. In these things are considered as a contraindication for doing balloon mitral valvotomy. There is one classification for LA appendage clot, the Dr. C. N. Manjunath's classification. So yeah, according to this classification is commonly used because up to class 1A, 1B, and 2A, we can consider for PTMC. 2B and higher above, we don't do the PTMC procedure. So 1A is LA appendage clot, which is restricted to LA appendage. Then 1B is LA appendage clot, just protruding to the body, but above the plane of fossa ovalis. Then 1A is LA appendage clot. 1B is LA appendage clot protruding to LA cavity. 2A is LA roof clot, but restricted to the above the plane of fossa ovalis. 2B is LA roof clot, which is coming below the plane of fossa ovalis. 3 is over the interatrial septum. 4 is mobile clot attached anywhere in the body, but it should be attached, but it is mobile. And 4 is ball valve thrombus. Ball valve thrombus is an indication for emergency surgery. You need to remember. And also if there is LA body clot, which is mobile, there also we don't attempt any PTMC. 2B and above, usually PTMC is contraindicated. We have to give anticoagulation. So that's about mitral stenosis. Then coming on to the mitral regurgitation. So this is another common pathology. Here it can be due to acute traumatic fever and chronic traumatic heart disease. Both can cause mitral regurgitation. We need to see for my MR in both the settings. Acute traumatic fever is common in children between 5 to 15 years and chronic traumatic heart disease in adults. So here comes the role of both M-mode and 2D. They give the clue to the severity and chronicity of MR. LV size and function assessment is very important here. And they determine the timing of surgery. So there are both qualitative and quantitative indicators of severity of MR. So quantitative ones are the size of the color jet, like vena contracta, then PISA, effective regurgitant orifice area, regurgitant volume, and regurgitation fraction. So whenever there is MR, so pictorially we can tell the narrowest orifice of the regurgitation jet at the level of the mitral valve, that is called as vena contracta. So size of the color jet we assess. So that is actually less accurate method. It is one of the qualitative method. It is profoundly affected by the instrumental setting, preload, afterload, the blood pressure, LA size, and compliance. Image of the spatial distribution of the velocities or in LA, it should not be heavily dependent upon. So many times we commonly use this, but it is not more reliable method. So here we assess the regurgitation size compared to that of the LA size. For example, in this image, we can see there is MR. This much is occupying. It is less than 20% of the LA size. So we classify this as mild MR. Here we can see that the MR jet is occupying more than 40% of the LA volume, and then we call it as a severe MR. This is a rapid eyeball method, but this alone should not be taken into consideration. So in hypertensive patients, even a mild MR, because of the increased afterload, it can increase. So hence we need to control the blood pressure and reassess. And whenever there is a central jet, there will be entrainment of the RBCs, and they may falsely appear more severe. And whenever there is an eccentric jet because of the wall hugging effect, it may be underestimated if we just look at the jet area. So this is an example for central jet MR, and this is an example for eccentric jet MR. So vena contracta is one of the more reliable determinant of assessment of the severity of MR. It is the diameter of the jet as it leaves the regurgitation orifice, the diameter which we take at this level. So it is a narrow central flow jet, possible in 90% of the patients to assess, and it does not depend upon associated other valvular lesions like MS or other aortic valve disease. So vena contracta is imagined in MR in parasternal long axis view or in apical four chamber view. Narrowest orifice we need to consider, and we need to measure it in a zoom with zoom mode. And we can take average of 2 to 3 beats, and it will be better if we measure in 2 orthogonal views, for example, in apical four chamber view and parasternal long axis view. And if it is less than 3 mm, we call it as a mild MR. If it is more than 7 mm, it will be a severe MR. Between 3 to 7 mm, it will be relatively less reliable, and we can, if it is depending upon other parameters, we can classify it as a moderate MR. So here is one of the example for we measuring the vena contracta. So here the vena contracta was 6 mm. So this is the narrowest orifice of the regurgitation jet measured at the level of the mitral valve. So strength of vena contracta, it works well both for the central and eccentric MR, doesn't depend upon other factors, but it will not be reliable if there are multiple jets. And intermediate value will be less reliable. And another method is assessing by making use of pulse wave Doppler across the pulmonary vein. So it is specific for severe MR. In the presence of severe MR, since MR occurs during systole, and the regurgitation MR jet, it goes into the pulmonary vein. So whatever the systolic flow, normally during the systole also the pulmonary valve flow will be forward towards the LA. If there is flow reversal, that is systolic flow reversal, as we see in this image, so this S wave, instead of upside, if it comes down, that is called systolic flow reversal in the pulmonary vein. Then it is called as, there is one of the criteria for severe MR. So apart from that, we can put the pulse wave Doppler across the mitral valve. If the E wave velocity is more than 1.5 meters per second, that also classifies for severe MR. Then we see E wave and A wave. If there is a dominant A wave, that is A more than E, that excludes severe MR. And also we can look for mitral valve to aortic valve tissue velocity integral ratio. If it is more than 1.4, it suggests severe MR. If it is less than 1, it will be mild MR. And continuous wave Doppler in severe MR, we don't have to measure the peak velocity. It mainly depends upon the intensity of the spectral Doppler. So the intensity of all these spectral tracing depends upon the number of RBCs. More severe the MR, more dense will be this spectral tracking. If it is the signal intensity is higher, then it suggests severe MR, and never depend upon the velocity. It doesn't correlate with the velocity, the peak velocity. Don't have to measure that. Then associated other findings of severe MR, we have to look for mitral valve. There is MR. So in rheumatic heart disease, there can be sometimes leaflet prolapse. Sometimes there can be flail leaflets because of the caudal tear. Sometimes there may be associated infective endocarditis. All these things we need to rule out. And look for flail leaflets, ruptured papillary muscles. Then dilated LA, LV, because if LV is getting dilated, that is an indication for sending the patient for surgery. And MR is always associated with hyperdynamic LV. So normal EF usually we tell is more than 55%, but in the presence of MR, the EF of more than 70% is considered as normal. So if it is less than 70 or 65, then we consider it as a decreased EF, and EF of less than 50 an indication for sending for surgery. And also look for associated pulmonary hypertension. So to summarize, what are the criteria called as severe MR? One is if there is a flail leaflets, usually associated with severe MR, dilated LALV, EF if it is reducing, then large color flow jet with a jet area more than 40% of the LA, continuous wave Doppler showing dense full envelope MR, then systolic flow reversal in the pulmonary vein. If the E wave in the pulse wave Doppler across the mitral valve, if it is more than 1.5, and mitral to aortic valve TVI more than 1.4, then venocontracta of more than 7 mm, and PISA radius more than 10 mm, and regurgitant volume. Based on the PISA radius, we can calculate regurgitation volume and regurgitation fraction. If regurgitant volume more than 60 ml and regurgitation fraction more than 50%, and if the regurgitant orifice area if more than 0.4 centimeter square, these fulfills the criteria for severe MR. These things are quantitative methods, and it take some calculations we need to do based on PISA. So it takes some time to understand this and to practice that. Then coming on to the next valvular heart disease in rheumatic heart disease, aortic stenosis. So aortic stenosis, the most commonly isolated aortic stenosis is usually due to calcific aortic valve in the old age because of degenerative process we get. In young individuals, it is due to rheumatic heart disease, and always it is associated with associated mitral valve disease. So the normal aortic valve orifice area is 2 to 4 centimeters square, and normal aortic valve has got 3 cusps as we see here, and normal aortic valve, when we see in the Panson's short axis view, we'll see in this way, it is called as inverse Y or reverse bend sign. So that is a normal appearance of the aortic valve, and there will be unrestricted systolic opening. So the normal aortic valve orifice is 2 to 4 centimeters square, and aortic leaflet separation will be 2.5 to 2.6, and velocity normally will be 1 to 1.7 meter per second. In rheumatic process, what happens? There will be leaflet thickening, commissural fusion, there will be calcific nodules on both the surfaces, and there will be often associated with regurgitation or stenosis. Invariably, there will be associated mitral valve disease. So, changes. So here we can see there is aortic. So here we can see that the video is not playing. Oh, okay. Okay. So here it's not see. So here we can see that the aortic leaflets are thickened, and we can see the forward. So to assess the severity of aortic stenosis, we make use of mainly parasternal long axis view and in apical 5-chamber view. These are the two important views. So here we can see that there is aortic leaflets are thickened, and there is forward turbulence suggesting and restricted mobility of the aortic valve. When this is there, we should suspect severe aortic stenosis. And here we can see the parasternal short axis view. The leaflet opening is restricted. It's not playing here. In this one. What happened? So, everything paste, it was good. It's not playing. No, previously it was there. No, we can go to that back. End of the show. Okay. Okay. Why it became smaller? Previously it was coming full screen. You don't come? No. PC screen only, I think. Yeah. Slideshow. Just continue. No. No. So parasternal short axis view, again here we can see the leaflet separation, which helps in assessing the severe, which helps in suspecting how severe is the aortic stenosis. Now coming on to the assessment of severity, aortic valve area in mitral valve by planimeter we usually measure the mitral valve orifice. Same principle we cannot apply it for the aortic valve. Here to assess the aortic valve area, we have to depend upon the continuity equation. It is aortic valve area continuity equation, direct planimetry we cannot use. And for clinical decision making, always depend upon the flow rate, mean aortic valve gradient, LV function size, wall thickness, and degree of valve calcification. Now coming on to the severity of AS, so normal is 2 to 4 centimeters square. Mild, moderate, severe depends upon the gradient. So less than 25, 25 to 40, more than 40 millimeters of mercury, we call it as a severe aortic stenosis. Then coming on to the jet velocity, less than 3, 3 to 4, and more than 4. And coming on to aortic valve orifice area, more than 1.5, 1 to 1.5, and less than 1, we call it as a severe. And usually if there is associated LVH, in the absence of hypertension or the other causes of LVH, it is usually, if there is LVH, it usually suggests severe aortic stenosis. Then echo features of severe AS. So one is the aortic valve orifice area less than 1, calculated by continuity equation, or less than 0.6 centimeters square per meter square of body surface area. Peak velocity, which we measure in apical 5-chamber view. So where we get we have to, in apical 5-chamber view, put a color Doppler, and where we see the turbulence, there you put the continuous wave Doppler. If the velocity is more, if it crosses 4, or if the mean gradient, when we trace this, if the mean gradient is more than 40, it suggests severe aortic stenosis. Very severe AS we call if the mean gradient is more than 40 or if the peak velocity is more than 5 meters per second. Then coming on to the aortic regurgitation, here also we do depend upon M mode. Mainly we look for fluttering of the antemitral leaflet. We look for use M mode, and also to assess the chamber dimensions. 2D and color Doppler to assess the jet width, jet area, and vena contracta, and Doppler assessment to assess the PISA and volumetric measures like regurgitation fraction, regurgitation volume, and regurgitation orifice area. So here in the M mode, what we see, as I told, we look for the fluttering of the antemitral leaflet. So that suggests severe AR. Then hyperdynamic interventricular septum. Here we can see the hyperdynamic motion of the interventricular septum. Premature closure of the mitral valve due to rapid increasing LV and diastolic pressure can be seen in acute AR. So non-coapting leaflets at the aortic valve level, which we can make out in the parasternal short axis view at aortic level, also suggest severe AR. Reverse dooming of the AML, which can be seen in the parasternal long axis view, as we see in this image, also suggests severe AR and presence of LV dilatation. So here you can see this is a regurgitation or aortic regurgitation, and we can see that it occupies more than 65% of the LVOT, so suggesting severe aortic regurgitation. So coming on to the diameter of aortic regurgitation in parasternal long axis is one of the reliable method. So if it is more than 65%, we call it as a severe AR, 25 to 65% is moderate AR, and less than 25% is mild aortic regurgitation. And this is the same thing shown in this particular image. And in parasternal short axis view, we can see the regurgitation orifice area. Then vena contracta, we usually measure in parasternal long axis view, and if the width is more than 6 mm, we consider it as severe AR. Here we can see a regurgitation is there, and the vena contracta was 10 mm, suggestive of severe aortic regurgitation. And in continuous wave Doppler, so look for the density of the regurgitation orifice. If it is very dense, as we see in this image, that suggests severe AR. So larger the regurgitation volume, then greater, darker will be the regurgitation jet. Also, we can use pressure half time here. Here, there is a time taken for the jet velocity to reduce by 50%. And if there is a gradual decline in the mild AR, there will be smaller increase in the LV and diastolic pressure. So there will be a gradual decline and fat deceleration slope. Pressure half time will be more. In severe AR, here we can see the pressure half time. If it is greater, then it is mild AR. If it is sharp decline is there, then it is more severe aortic regurgitation. And also we can look for the density of the envelope. It is opposite to that of mitral stenosis. In mitral stenosis, more the pressure half time, more severe is the MS. In aortic regurgitation, more the pressure half time, it will be less severe, will be the aortic regurgitation. Then flow reversal in the descending thoracic or abdominal aorta. If this we can assess by pulse wave Doppler or color Doppler. In the suprasternal view, we can look for the descending aortic flow. Pulse wave Doppler or color Doppler can be used. Pan diastolic flow reversal with the end diastolic velocity more than 20 centimeters per second suggests severe AR. So this is a suprasternal view. Pulse wave Doppler across the arch. Here is the end diastolic velocity. This one is almost coming to around 30 meters per second, suggestive of severe aortic regurgitation. So pulse wave Doppler in the descending thoracic aorta we need to use. Or we can use color Doppler also, as we show in this image. Here we can see this is the diastole. There is pan diastolic flow reversal. We can see this red flow. Red flow is coming towards because of the flow reversal. Normally there will be flow in the descending aorta will be away from the will be downwards. Here because of aortic regurgitation there will be diastolic reversal of the flow. So here we are getting the red flow towards the probe. That suggests there is severe aortic regurgitation. Then in other quantitative parameters like effective regurgitation orifice area by PISA, regurgitation volume by continuity equation, and regurgitation fraction you can use. They are more acute but rarely measured as it is time consuming in clinical practice. So the criteria for severe chronic AR are: one is dilated LV, non-copting leaflets, color flow regurgitation jet more than 65% in Pascal long axis view, then vena contract of more than 6 mm, pressure half time less than 200 milliseconds, then continuous Doppler showing dense signal, then hollow diastolic flow reversal in descending thoracic aorta, effective regurgitation orifice area more than 3 mm square, or regurgitation fraction more than 50%, or regurgitation volume more than 60 ml per beat, suggest severe severe aortic regurgitation. Then whenever there is aortic valve pathology, either AS or AR, we also need to measure aortic dimensions, because aorta, ascending aorta, and also the sinuses and ascending aorta, these tends to get bicuspid aortic valve. However, in bicuspid aortic valve, usually the aortic sinuses are spared and ascending aorta gets dilated. In Morphons, both the sinuses as well as the ascending aorta gets dilated. In which part of cardiac cycle we are supposed to measure? In the mid systole. We are supposed to measure the aortic annulus and other parameters in the end diastole. In parasternal long axis view, we are supposed to measure. If these are dilated, there are specific cutoff to indicate for surgery. Then coming on to the tricuspid valve pathology, tricuspid regurgitation is one of the common lesion which we see. It can be either functional or organic TR due to rheumatic heart disease itself. Majority of the time it is functional, rarely it can be organic. So here we can see the aortic leaflets are, tricuspid valve leaflets are thickened, there is restricted mobility, and there is severe tricuspid regurgitation. It is organic TR due to rheumatic heart disease itself. So in these cases, based on the other parameter, if it is a severe TR, then we may have to address this pathology also by leaflet, by going for tricuspid annuloplasty. So when we call it as severe TR, so if there is dilated RV, RA, or if there is dilated IVC, hyperdynamic RV, rightward bulging of the if there is bulging of the interatrial septum, then so other things which we look for are measuring the vena contracta of the tricuspid valve regurgitation jet. If it is more than, if the vena contracta is more than 7 mm, it suggests severe TR. And same thing as we use for mitral regurgitation, same thing is extrapolated here also. If it is occupying more than 40% of the right atrial area, then it suggests severe ER. Then jet area, if it is less than 5, then it is jet area. If it is less than 5 centimeters square, then it is mild. More than 10 centimeters square, then it is severe. Vena contracta of more than 7 mm. This is what we commonly use. That suggests severe TR. So what are the criteria for severe TR? One is non-coopting leaflets or the fly leaflets, jet area more than 10 centimeters square, vena contracta more than 7 mm, or PISA radius more than 9 mm, more than 0.9 centimeters square. If the dense signal is more dense, signal intensity is more dense and triangular with early peaking, and if there is systolic flow reversal in the hepatic vein, these suggest severe TR. So this is one of the example for severe TR with associated mitral valve disease. Here we can see the mitral valve disease is also severe, and also associated TR is there, which also need to be addressed. So this is one of the example for, I think the video is not playing, severe TR due to infective endocarditis. Yeah, here we can see the leaflet is torn. So there is a leaflet is flail and there is severe TR. and IVC will be dilated when there is a severe TR with the pulsatile flow reversal in the hepatic vein. If we put a pulse wave Doppler across the hepatic vein, we get systolic flow reversal. This is the example. There is systolic flow reversal in the aortic, in the systolic flow reversal in the hepatic vein. So these are the criteria, that is dilated RA, RV, and IVC, very large jet more than 40%, vena contracta more than 4, and E wave will be more than 1, and PSA radius more than 9 centimeters square. And also always we should measure, so aortic tricuspid valve annular diameter, if it is more than 40 mm square or more than 21 mm per meter square of body surface area, it is an indication for sending the patient for associated tricuspidal pathology repair also. Usually they do tricuspid annuloplasty to achieve the coaptation of the tricuspid leaflets. Then coming on to the tricuspid stenosis, this is quite rare. If it can happen due to rheumatic pathology, almost always there will be associated mitral valve disease, and it is always due to rheumatic pathology. There will be diastolic dooming of the tricuspid valve, and mean gradient of more than 2 mm square is considered significant. So severe TSS if the gradient is more than 5 mm square. So echo features of severe TSS, one is thickened distorted leaflets, dooming. Then we can see the valve area less than 1 centimeter square, and tricuspid pressure half time more than 190 meters per second, and mean gradient more than 5. But however, it is very highly variable, depends upon the heart rate, flow rate, and respiratory cycle also. Here we can see tricuspid stenosis with associated eccentric severe TR. So this is how we put the continuous wave Doppler and measure the gradient. Here the gradient is 8, suggestive of severe TR. And also, whenever there is valvular heart disease, always we measure pulmonary artery pressure by using TR jet, continuous wave Doppler. So as we all know, we use Bernoulli equation, and accordingly we have to grade the pulmonary artery systolic pressure as mild, moderate, and severe. And to assess the RA pressure, we look for IVC, diameter, and its respiratory variation. And if the RA pressure is 5, we give it as normal. If the RA is 10, that is IVC, if it is 15 to 21 mm and partially collapsing, then we put the RA pressure as 10, and if it is dilated and non-collapsing, we put the RA pressure as 15 millimeters of mercury. And coming on to the acute traumatic fever, few criteria. So what are the findings in acute traumatic fever? We get annular dilatation. This is in children, we see commonly acute traumatic fever between 5 to 15 years. There will be associated fever, joint pain. These findings will be there. And when these patients are sent for echo, we should look for aortic, mainly the mitral and aortic valve pathology. Usually there will be a regurgitation lesion in these cases. Apart from assessing the regurgitation, we should look for annular dilatation, caudal elongation, caudal rupture, resulting in fly leaflets with severe MR, and anterior mitral leaflet prolapse can be there fairly. The posterior leaflet prolapse can also be there. And in aortic valve, we can see the irregularity of the leaflets, nodularity in the leaflets, coaptation defect, restricted leaflet motion, and leaflet prolapse. So the Doppler criteria for rheumatic valvulitis, to call it as a pathological MR, all these criteria should be fulfilled. That is seen in at least 2 views. Jet length should be more than 2 centimeters in at least 2 in 1 view. And peak velocity should be more than 3 meters per second, and pan-systolic jet in at least 1 envelope. And to call it as a pathologic aortic regurgitation, all these 4 criteria should be fulfilled. Seen in 2 views, jet length should be more than 1 centimeters in at least 1 view, peak velocity should be more than 3 meters per second, and pan-diastolic jet in at least 1 envelope. To distinguish from physiological MR and AR, these criteria are put up. To summarize, echo, both 2D, M mode, color, continuous wave Doppler, pulse wave Doppler, all these are very important as a diagnostic are very essential to assess the severity. No single parameter is completely accurate. Integration of multiple parameters is essential to assess the valve. Anatomy, chamber size, Doppler parameters should all be used for accurate assessment. Thank you.
Thank you, sir, for the valuable presentation.
Any questions? So if you are planning, 3D has also got some importance, especially in assessing MR. And if you are planning some interventions, then it is very important, and also during intra-op. So that also has got a role. And also the transesophageal echo, very important, especially when you are looking for LA appendage clot. And if you are planning PTMC, always we have to do transesophageal echo, rule out LA appendage clot, and then plan for PTMC if the patient is in atrial fibrillation. Okay, thank you.
I request Dr. Rita Varri ma'am to kindly present the mementos.
Sairam, now we'll break for lunch. Before we break for lunch, let us have all together have a group photo near the dome area. We request everybody to use that door and let us all assemble there. Have a group photo, then go to lunch. And please join ASAP as we are running out
We'll,
of
we'll
time.
meet near the registration counter outside. That's a dome area. After that, you go down the ramp and into the canteen. That's for the delegates, and faculty will have with us behind in the faculty room. We'll have a quick snap. We'll have Solas's talks back to back after lunch immediately. And there is a specific request for all of you to please join back ASI. Thank you.
Happy birthday, Ante. Thank you.
अंकित कसं